This presentation will be discussing the principles of pharmacology. We're going to go over the overall pharmacologic history, the physiology of medications on the body. We're going to go over classes of drugs, different types of classes of drugs that we have based on different body systems that they're used on. And then we're going to spend the second half of the lecture going over specific emergency medications that you find in your drug box today. So to understand medication administration is to really be a good medic. Being able to interview your patient, do a thorough assessment, and make a decision that this patient requires medication is a true skill and takes experience, time, and many patient contacts to become comfortable with. But just understand that when you give a medication, you can't take it away. So you have to be thorough and not just jump in and make a quick assumption and treat. Because these medications have good clinical effects, but they have some severe side effects that can be life-threatening if given to the wrong person, if given in the wrong dosage, if given at the wrong time. So we have to be cautious. And I know when I talk to a fellow medic, I know I'm preaching to the choir. That we are cautious and we do ask all the questions. But think about when you're doing your assessment, it's almost adversarial in nature. You need to rule out certain medical conditions before you can move on with treating with medication. So if they answer a question or two wrong and you don't feel comfortable administering the medication, the best course of action is to err on the side of caution, which of course is better for overall patient care. Pharmacology is the study of how substances actually interact with living organisms by altering cellular function, by either causing cells to do extra work or by blocking cells from performing certain functions. Either way, it's dangerous if given improperly. Now, we've been using chemicals for centuries, and a lot of the medications that we give are derived from chemicals that were first produced hundreds, if not thousands of years ago. Pharmacology today is based on evidence and uses and cause and effect. So we have to be sure that medications we're giving to people out in the field have been vetted efficiently and thoroughly enough for us to feel safe in giving it in a universal way. So in order to do this, these medications have to undergo a litany of tests mandated by the Food and Drug Administration to make sure that they're effective, and more importantly, we understand the therapeutic levels that we can administer. This all came about in 1938 when the Food Drug Administration was actually created. Before then, a lot of people would go to disreputable snake oil salesmen who would give them medications and tonics telling them that this was helpful to them. They were untested, they were unlabeled, and in a lot of instances, they were deadly. So in order to combat this scourge, the Food and Drug Administration was formed, and they created this approval process that we have today. This approval process takes years and can cost upwards millions of dollars to get a drug approved for public consumption. Now, some of these medications that are out there are quote-unquote off-label drugs, meaning they haven't been reviewed or approved by the FDA. We're much more stringent with the medications that we can give in the emergency setting. We can't give these off-label drugs. However, we can give FDA-approved drugs to something that it's not originally intended for, but still accepted use. One example we have is giving Benadryl for a patient who is suffering from a dystonic reaction due to a Haldol intoxication. Now, in 1970, the Controlled Substance Act was passed, and it was built on the framework of the Harrison Narcotic Act at early turn of the century. And what the Controlled Substance Act did was it recognized that there are substances that need to be basically regulated very strongly because they have a very high potential for abuse. And they classified these drugs. They put them into this group and deemed them narcotics. And there's different types. There are stimulants, there are analgesics, there are opioids, there are uppers and downers. There's all sorts of different kinds of drugs. And steroids are now classified as controlled substances. But we give them schedule numbers based on their clinical use and their abuse potential. A Schedule 1 has very little clinical use and has a very high abuse potential. So examples of Schedule 1 controlled substances or narcotics: heroin, marijuana, LSD. Now, if you think about this, heroin had a clinical use at the turn of the century, at the beginning of the 20th century. Heroin was a drug that was given by doctors to their patients who were addicted to morphine. Now, I want you to think about that for a minute. So you're addicted to morphine, so to get off of the morphine addiction, we're going to prescribe heroin. So you can see how our society has moved and shifted, and the Harrison Narcotic Act didn't fill out a lot of these new drugs that the Controlled Substance Act of 1970 actually was able to group together. So, Schedule 1, high abuse potential, very, very little clinical value. Then we start moving on. Schedule 2, now we start seeing, you look at these drugs, they have a high abuse potential, but they have legitimate medical purposes. Fentanyl, Ritalin, even cocaine is used in the surgical setting. And now as we're going down further, the medicinal value increases and the abuse potential drops to where you hit Schedule 5, low potential for abuse, and a good example of that is a narcotic cough medicine. What are medications? They are chemical messengers that you are giving as a way to communicate with your targeted cells in order for them to do a function that you are requesting. Okay, so think about that. It's a chemical messenger. So how are these chemicals formed? Well, we have the synthetic kind, which is a chemical that's completely man-made, and then we have our semi-synthetic. And these are more historical derivatives of plants or animals or mineral sources. And, an example of a plant source, you can get aspirin from the bark of a willow tree. A lot of antibiotics are brought up from microorganisms themselves. Minerals, of course, we have the iron and the calcium. So you can see all the different sources that we can draw from to create these types of medications. Licensed pharmaceutical companies are given the responsibility of making sure the drug that they produce and ship and present to the community is always standard in its concentration, its purity, okay, its ability to retain its potency, otherwise known as an expiration date. And you can see the different forms of medication. It's a good review. You have your capsules. Capsules are a solid medication that's in a dissolvable cylindrical shell that's usually made out of a glycerin or a gelatin. And you see the examples. You have Benadryl pills, acetaminophen. These are PO drugs that are designed to break apart inside the GI system. As are some tablets, and you have tablets that are compressed powders, and they can be dissolvable like baby aspirin, or they can be coated. They call it enteric coating, which bypasses the oral mucosa and allows for GI digestion, which takes a little bit longer to see the effects. And you see those there. We have drops, we have skin preparations, transdermal, suppository to access the rectal vascular route, liquids, and inhalers and sprays. And you see a lot of inhalers now, and the new sprays that are out there, the intranasal routes of medication administration. As medics, we see this now, of course, with Narcan, and you're going to maybe even see this on BLS trucks, where Narcan will be administered intranasally. It's actually it's shown to be very effective, almost as rapid as an intramuscular injection. So the process of creating a drug, it starts off first with an idea and a plan. We want to address cardiovascular disease. We want to work on pain management. So the drug itself is created in the lab, and it's given a chemical name. And it goes through the process of development. There are 3 to 4 to sometimes 5 phases of clinical trials that involve being in the lab, that involve animal testing, human testing, double-blind studies, review panels. It takes years and years and years. But when it finally is approved by the FDA, it's given an official name. Okay, now the official name is a lot like the generic name. It might be a slightly different, but the generic looks a lot like the official. The official name, in most cases, I'd say about 97 to 98% of FDA-approved drugs are the same as a generic, except for one very important thing. They're always followed with a comma and the initial USP. That stands for United States Pharmacopoeia, because when drugs are approved by the FDA, they're placed in this national database, this formulary, this pharmacopoeia of drugs. So to know that you're looking at an official name is to see that USP after it. One very common generic drug that we see that's generic name is same as the chemical name and the official name followed by USP is oxygen. You see on your oxygen tanks, it'll say oxygen, comma, USP. So that's a perfect example. Now, once the drug company has gotten the approval and the drug has been placed into the United States Pharmacopoeia and the generic name is there and the official name is there, now the drug company has a patent, usually 20 years, where they are the sole manufacturer of that drug. And to award that and to make sure that they understand, the public understands that this is the actual correct drug, drug companies get to name it. That's known as the trade or brand name. So for example, you've got ibuprofen. Ibuprofen is the ibuprofen, USP is the official name. The generic is ibuprofen. The trade name is Motrin. So an offshoot of this United States Pharmacopoeia is the Physician Drug Reference Guide. And what it does is it actually talks about interactions of drugs, indications, contraindications, all these very important things. And we have actual bound books, we have electronic sources of this physician or desk reference or PDR. Using a reference source is vital, necessary, and a requirement in hospitals to actually have at nurses' stations and doctor stations a way to access the PDR. What's in your United States Pharmacopoeia, what's in the PDR, Physician Desk Reference Manual, is the medication itself, and every medication is given a profile. So I talked about the official name, but what else do they have? Drugs are categorized. They're given a class of medication. What are they used for? Are they antiarrhythmic? Are they analgesic? It discusses the uses and indications, the pharmacodynamics, the mechanism of action on the body and on the cell. Risk factors, very important, are pregnancy risk factors. Understand that while mom and fetus do not share blood supply, they each have their own supply, they do, through the placenta, share almost every product, including, but not limited to, oxygen, glucose, proteins, and drugs. So whatever mom takes, she's sharing with the baby. Some of these drugs have pregnancy warnings associated with them when they cause fetal damage. We have contraindications when they're absolutely not appropriate. Talks about the ways you can find them. They're approved ways of disbursement into the body, the forms of the drugs, the dosages, potential incompatibility with other types or classes of drugs or specific drugs, adverse effects you want to look for, those side effects. Because remember, when you're administering a drug, you're giving it to the entire body. So in addition to the targeted cells that you're hoping to go for, there are other cells that can pick up on this too, have a response that could be an untoward response, a bad response. That's known as a side effect. Manufacturers are mandated to provide instruction labels, reference material with every drug. Where do you find that reference material? Well, when you're restocking from a cardiac arrest and let's say you're pulling out 5 or 6 epinephrines and you take them out of the box and there's that paper attached to it, it's the stuff you usually throw away, that's the reference material. And it has all the information that you would find in a physician desk reference and the United States Pharmacopoeia. People who work in hospital-based EMS systems encounter this a lot. Drugs are actually purchased by hospital pharmacies to meet the needs of that hospital. Sometimes the needs of the hospital will outweigh the needs of the resident ambulance department. So, case in point, the hospital that I used to be director of EMS for, we use Versed, and Versed is given in 2 milligram vials. 2 milligram vials are very effective for in-hospital use. They're used primarily in the hospital, more so than on the ambulance. One of the New York City REMAC 2012-2013 protocol says that you can administer Versed 10 milligrams IM. So what that means is you would have to draw out 5 vials of the 2 milligram Versed to administer the 10 milligrams. And now you're thinking about the amount of fluid that you can inject into a deltoid. Remember, subcutaneous is 1 cc and intramuscular is 3 cc. So we may have to give 2 IM injections to make the 10 milligrams. So I went to the pharmacy and said, can we possibly get a 10 milligram vial, or if not, maybe a 5 milligram vial? And they said the only ones that they are able to order, in addition to the 2 milligram, is a 50 milligram vial of Versed. So I thought, as an administrator, I would rather you drew up extra vials and give more injections than make a mistake, draw up 50 milligrams thinking it's 10 and administer it. So this is the challenge that EMS has in the marketplace when it comes to purchasing narcotics. In addition, medication needs to have proper storage and ability for ease of access by EMS and use. So there must be adequate protection, either a locked cabinet, extra medication on the ambulance. That allows for good convenience, not having to go back to your station and restock after every shift. They must be able to be safe in storage, especially in your bag. And that's usually done by putting them into protected bins, and they need to be identifiable very quickly. And as you know, a lot of drugs are packaged very similar. Because we're dealing with different manufacturers for different drugs, there's no standard approach. So you have to be very cautious when you're taking out that medication. Now, administrators will work very hard at making sure that all the drugs look different and are easily recognizable to you, but it's your responsibility to know the proper drug that you're administering. When you're storing medications, the best thing to do, remember, is avoid direct sunlight. That's why nitroglycerin is actually in a darkened vial, the nitro tabs, because sunlight will lower the efficacy of drugs. It will increase it'll speed up the expiration of drugs. So keeping them stored in a cold, dark area is optimal. When we're talking about cold, we don't want it to be too cold. Drugs like Lasix can actually freeze. Controlled substances have to have additional safeguards attached, and depending upon your region, state, but will determine exactly how you can store these drugs. But a general way of storage is making sure that it's under 24-hour supervision, the excess storage, and the medic on-site storage. So whatever you sign out, you're responsible for. The excess has to be under 24-hour watch, and that can be in the form of being in a dispatch center that's open 24 hours a day, being in the security office of a hospital or the pharmacy of a hospital that's open 24 hours a day. These are all acceptable methods of guardianship of these drugs. In addition, we have to make sure that we keep adequate records and are not only of usage but of waste. The FDA and the Drug Enforcement Agency actually track excess use of drugs, and they want to see the wasting of drugs. And then we talk about where they should be wasted. There's new policies out by the Environmental Protection Agency and the FDA that says that a lot of these drugs should not be wasted down a sink. We increase the amount of these drugs that's actually going into the sewer system, and a lot of cities actually use sewage and they filter it and turn that back into drinking water. This could actually affect not only our marine life, but also human life. So we want to be very careful where we dispose of wasted narcotics. And once again, go back to your agencies and think about, ask, what is the proper disposal method for narcotics? The bottom line is when you give medication, every little bit has to be documented. All usage, what's given, what's wasted. And there's no such thing in emergency medicine and EMS as multi-use drugs, vials. So getting, if you have epinephrine, high-dose epi, and you are going to give an IM injection of 1 to 1,000, and there's a vial that contains a total of 10 milligrams in 50 cc's, let's just say, that vial, one use only. If the cap is off of the vial, you have to make the assumption that it was used, and it cannot be reused. This not only talks about issues of hygienic, cleaning, maintaining aseptic technique, but also you don't know truly what drug is in there, if at all. So any uncapped drugs need to be disposed of, and any uncapped narcotics should be traded out, disposed of, or at the very least documented and notify your supervisor. So once again, you know, it's our role as paramedics to actually be the guardians of these medications, to have respect for them. They're not toys. We don't just decide, well, what the heck, let's just try this and see what happens. So, and the reason we don't think that way is because we have respect for the drug and we understand pharmacodynamics, kinetics, and pharmacology. When we're giving a medication, we are sending an actual message to the targeted cells. How do we do that? Well, the chemical messenger that we're sending, whether it's a natural or synthetic, is known really in the body as a hormone. And the endocrine system operates with hormones too. Hormones can be best described as the emails that you send out as messages. Now, when you send a drug into the bloodstream, there are cells that have receptor sites. These are proteins that actually sit on the cell membrane and they monitor the blood flow. And the blood flow at the cellular level, the capillaries, is very slow. It's one red blood cell thin, so there is really a great way to monitor the blood going by. And when these receptors find a chemical messenger or hormone that they recognize, they grab it. Just like when you send an email to somebody, you're sending it actually to the entire World Wide Web, but it's actually encoded for the sole purpose of being interpreted by that targeted email address that's monitoring the World Wide Web continually. If you have Wi-Fi, you know, if you guys remember dial-up access, the only way you get your email is if you actually dialed online and then you got it downloaded into your inbox. Now we have almost constant, through T1 lines and cable modems, constant access to the internet, so we're always getting this information. So the cells are kind of like that. So they're constantly getting this information. Once that media, cell receptor, is activated, it creates a process inside the cell. The process is instructing transcript RNA to create a protein. Now, what's important about protein? Protein is the language of cells. It's how cells communicate with each other. Proteins, to review real quick, are strands of amino acids. Amino acids, you can say, are the words, and proteins are the sentences of cellular communication. So when you give that order, that receptor is stimulated, it creates a messenger through transcript RNA and messenger RNA to create this protein in the ribosome that will have the cell do a specific function. It may ask them to do a specific function faster, stronger, better, in the case of cardiac cells, when they're stimulated by a beta receptor. It could tell them to do something less, like beta receptors that are stimulated on the smooth muscle of the bronchioles, causing relaxation, and in the process, bronchodilation. It could also have a much different command. Beta receptors that are located on the liver, that when activated, create a protein message that instructs the cell to release glycogen that's stored in the liver, convert to glucose, and release into the bloodstream, known as glucogenesis. This is one receptor, one beta receptor, creating different protein commands to the individual cells. That's the nature of pharmacology. That's how it changes the functions of the body, either for good, or increase, or for bad, or to decrease. Whatever it does, it will send out that chemical messenger that's interpreted by the cell, creating a protein, instructing the cell to do a specific function. Medications have a very narrow, what we call therapeutic index, or window. Too little, no effect on the body. Too much, toxic. Everything has a toxic level. Everything. I mean, we're 60% water, yet we can drown. So understand that drugs are very similar. Some have a very wide therapeutic window, very large one. Others have a very narrow one. One example of very narrow therapeutic index is Coumadin. Just enough will allow for, it's a strong antiplatelet. Too much, and you've got rat poison. That's what we talk about when we say toxicity of a drug. So when you're administering a drug, the reason it doesn't stay permanently, because the body has a system in place to break down any type of hormone that it comes across. And it does it through an enzymatic process. These enzymes will biotransform and eliminate the drug. Getting in the drug is either through absorption, and we're talking about skin or oral mucosa, but a direct way is distribution. We're talking about the parenteral route, pushing it into the bloodstream directly. Distributes it evenly across the body. If it's absorbed, it's going to be distributed evenly across the body, but it's going to be a little bit slower. So what I just talked about, this is pharmacokinetics. Receptor sites are sitting on the cell membrane. They have an external portion and they have an internal portion. These cell receptors are monitoring blood flow, looking for hormones or chemicals that will activate them. So when a medication, a hormone, a molecule, binds to a receptor site, there are a variety of things that can happen based on that receptor site. Receptor sites will instruct a cell to do certain functions. I talked about beta receptors with the heart, increased inotropy, increased chronotropy, and the lungs, bronchodilation through relaxation of the muscles, and the liver, glucogenesis. But they do other things too, like they will allow channels to open, which then will allow ions to diffuse across. Perfect example of that, acetylcholine is a chemical messenger transmitted by the somatic nervous system across to skeletal muscle. And when the receptors on the skeletal muscle that receive the acetylcholine are stimulated, they open up sodium channels, which allows sodium to come in, and we have muscular contraction. Acetylcholine and even epinephrine and norepinephrine, those are indigenous chemicals or hormones. Exogenous chemicals are medications that we administer. And as science has gotten better in understanding how drugs interact with receptors and really looking at receptors from a molecular level, they've been able to determine that there are different types of receptors within the same class. That's why we come up with beta-1 receptors, beta-2 receptors. Beta-1 receptors located on the heart, cardiac cells. Beta-2 receptors located on the smooth muscle of the bronchioles. So drugs are given that are specific. An example of a beta-2 specific drug is albuterol. So what ends up happening is the targeted organ, which is the smooth muscle of the bronchiole, is more affected than the non-targeted, which is the cardiac. When you're administering albuterol, of course, you want bronchodilation. You don't want the cardiovascular side effects. Some of our older beta agonists, you would have the cardiovascular, which was put the patient into a risk factor, this side effect. So I talked about an agonist. Agonist turns on a receptor, activates the creation of a protein that gives the cell a command to follow and carry out. Antagonists, they block receptor sites. So what you're looking at from left to right, the before drug, you see the natural chemical locking onto the receptor site, okay, which does normal cellular activity. Now, when you give the drug, you're enhancing it. You give an agonist. So the agonist drug will actually enhance the cellular activity that was normally in process. Other types will give antagonists that will block not only the natural chemical, but any other medications that are agonist in nature for that cell receptor. So this ability to have a cell receptor be attracted to and allow attachment of a chemical is known as affinity. The ability for it to stay active on the cell receptor is known as its threshold level. So agonist medications will bind with receptor sites. And you can see, I mentioned the beta-1, beta-2 agonist receptor sites. We also have alpha-1 and alpha-2. Alpha-1 are found on the arterioles and venules, and they cause vasoconstriction. Alpha-2 drugs allow for a restriction of insulin and glucagon secretion. It inhibits norepinephrine release, so it kind of going to flip you into parasympathetic tone, or maintain parasympathetic tone. Dopaminergic receptors, you find them on the renal mesenteric arteries, but there are all different types of dopaminergic receptors in the brain, skeletal muscles, all over the body. Dopamine is a very, very important hormone for normal body function. Nicotinic receptors, this is where you see the acetylcholine. It interacts with acetylcholine at the muscles, at the skeletal muscles, to allow for muscular contraction under voluntary control. But now muscarinic 2 receptors are in the heart, and they work very similar to the nicotinic receptors, but they work to increase parasympathetic tone by inhibiting sympathetic tone. So these receptor sites, when activated, will send out specific messages to the individual cells, telling the cell what to do through a process of creation of protein, the language of cells. So when the initiation of the drug and the alteration takes place is your threshold level. How much you need to get the desired effect is known as the potency. The efficacy is the ability to initiate the cellular activity. So potency is the desired, the amount required to achieve the efficacy. And now when we talk about agonist medications, we're trying to increase the response, so we'll increase the dose. So there's that period of threshold when nothing's taking place, and then we see a rapid rise. As our dose increases, the effect increases until we reach our maximum effect range. Now with antagonist medications, we're talking about blocking these receptors. It inhibits normal cellular activation and, in some instances, functionality. We can use antagonist medications to prevent the agonist effects of these artificial medications, these exogenous medications. Perfect example is how Narcan works to combat a heroin overdose. When you take heroin, it's an opioid. It affects opioid receptors in the brain that trigger dopaminergic release that causes euphoria. But it also gets in the way, since it's down in the limbic system right by the diencephalon and the pons, it gets in the way of the brain's ability to monitor homeostatic activity. And one big thing it does is it prevents the body from looking at levels of CO2 in the blood and the pH of the cerebrospinal fluid. And as a result, since we know that our drive to breathe is based upon and triggered by high levels of CO2 in the blood and the pH, the corresponding pH of your cerebrospinal fluid, there's no monitoring of that, there's no trigger to breathe, and what ends up happening is the patient goes into respiratory arrest. So the drug that we give, Narcan, is a opiate receptor antagonist. It blocks the opiate receptors. It's so potent that it knocks off the heroin or the opiate that was on the receptor to begin with. That's why you see a rapid, sudden change in the patient's behavior. Their ability to breathe immediately increases. And you find they take huge gulping breaths. Why? Because the brain that just got woken up, the diencephalon, the apneustic center, is like, oh wow, these CO2 levels are incredibly high, so I'm going to end up taking a huge gulping breath to try and correct any problems. Perfect example of an antagonist medication. By definition, Narcan is known as a competitive antagonist. Now, a non-competitive antagonist would be an example of a beta blocker like metoprolol or labetalol. These patients who are on these medications, you're going to lower the response, but it's going to be it's going to block until new receptor sites are located or created by the body. And the cells create new receptor sites, because when a receptor site's overused, it starts to dissolve, break down, and as a result, the body doesn't have the same effect, and that's called building up a tolerance physiologically, but that's how it works cellularly. And you have your partial agonist chemicals. They will initiate activity, but the efficacy of the agonist will be much lower. So it's like a reverse potentiation. It drops down. Primarily, this is how drugs actually work in the body and interact with cells. It's through stimulation or blockage of the receptor sites. But we have other drugs as well. Okay, we have drugs that can target microorganisms like antibiotics, drugs that can break down fats in the cells, that can excrete excess water like a Lasix that can get in the way of actual reabsorption of water. And then, of course, things that can counterbalance toxic materials that were ingested or injected into the body. So antimicrobials target specific substances, not cells per se. They will go after specific types of pathogens, like bacteria, or in some severe cases, fungi. Chelating agents like sodium bicarb, they will bind with heavy metals and alter their molecular structure. Water issues, we have the diuretics, right? And then our electrolyte-based medications like potassium chloride, sodium chloride. These are medications that will balance out the lacking elements that we have. We're hypokalemic, we give potassium chloride. We're hyponatremic, we give sodium chloride. So there are different things that can affect administering medications to the body. And first of all, your choice of medication. What type of meds you're going to be getting. You got to know the right dose, the right route. Is it the right time? Is it the right manner? Meaning the right patient. And did we document and monitor correctly? Age plays a big role. The very young and the very old do not work well with drugs. There can be issues. With children, it's weight. With the elderly, it can be their way that they get rid of the actual components of the drug. In addition, we talk about the percentage of body water. Don't have as much of it when you're young. You reach your optimal period in your 20s and 30s, and then it starts to drop off, especially when you're older and you're taking medication that sometimes restrict water retention, like Lasix, can have an effect on different other drugs. So the inability to break down medications in the body can end up with longer lasting effects, so you have to be very wary of that. And before you give another bolus of a drug, you should reevaluate, reassess your patient, and find out if they're still showing signs of the drug's efficacy in the body. Don't just follow the protocol for the sake of the protocol. It's not a cookbook, it's a guide. With children, weight is very important. I always talk to medics when they're preparing to take their regional exams. And so when it comes to pediatrics, you got to think about two things. The number one thing you want to think about is age. because a lot of drugs are not given to children under the age of 1. In New York City, in 2013, a child who's under a year old who's wheezing does not receive any epinephrine. So we have to think about age first. Then we think about weight. Because the type of drug we're giving can have a real effect, avoid, we can go into a therapeutic toxic area by just changing the age by a couple of months because of the changing in weight. So you have to be as precise as possible in determining a child's weight. We need to know the child's weight in kilograms, of course, to make because we're administering drugs in milligrams or milliliters or micrograms. So we need to understand that there's different ways that we can achieve a correct weight of a child. One universal way is using resuscitation table. Other factors that can affect the environment. A hyperthermic metabolic state can increase the metabolism of the drugs, whereas a hypothermic metabolic state can impair the effectiveness. There are genetic issues that you need to address. Sickle cell disease is a serious blood disorder that can have an effect on administering medications. Finding out during your interview process underlying history, issues with certain medications can have a real positive effect towards optimal patient care. Pregnant patients. The reason why the FDA actually has pregnancy precautions is because of the physiologic changes that are occurring suddenly in this patient's body. Forget about the fact that their blood supply increases by as much as 50%. That makes issues with cardiac output. Hematocrit will drop. You can't clot as well as you could if you increase your blood supply. Respiratory tidal volume increases, the GI motility will decrease in addition, so biotransformation of the drug is going to be an issue for enteric drugs given by GI. So we have pregnancy categories, we list them A, B, C, D, and X. Now, why is it X and not E? Because X, we want to show you, is bad. Okay, it's bad. So you're looking at A, controlled studies show that there's really no evidence of damage to the fetus. Or what we like to say, it's remote, meaning that it could exist, but it's rare. Okay, and then it gets worse as we go down, where studies show that there is an issue and you have to use caution, especially if you take other medications. But X, okay, there is true evidence of fetal risk, and therefore it should be avoided. It's contraindicated in women. Now, of course, in the emergency setting, we want to treat mom and not the fetus. That's true. But also understand that these X drugs can also cause damage to mom as well. So a lot of protocols for pregnant patients are created avoiding these X drugs pre-hospitally. There's other factors, psychosocial factors, where anxiety can be different among other patients. Pain is different. What someone classifies as a 2, someone else can classify as a 12. So it's psychosocial. It's all different across all different socioeconomic classes. That's why we need to be aware of psychological clues. One big component of our medical population, especially in emergency medicine, are drug seekers, patients who will mimic extreme pain with the end effect of getting controlled substances, narcotics, as a way to get high. Okay, so how do we find this out? Through thorough interview. You know, our goal is to provide comfort and care for patients. Sometimes through an interview, it just doesn't make sense. The pain does not match the symptoms. So can you at that point withhold? Sure, that's your clinical decision. But if you're going to do that, you still should have part of your process transport to the hospital. But remember, we always want to err on the side of patient care. The patient's needs come first after our safety. So what type of responses that we have? We have our desired effects. This is known as therapeutic. And it's based on what the patient is complaining of. And what they complain of and what your test shows that there's an indication for a drug to treat this. Perfect example, chest pain, ST elevation on a 12 lead in leads. V1, V2, V3, V4 will tell you have a rule out MI, it's a STEMI classification located in the anterior septal artery. So based on your findings, your clinical findings, your diagnostic testing, vital signs are 160/90, a pulse rate of 80, respirations of 22, and a little labored. That would be an indication for nitroglycerin. They meet the indications for use. Giving that nitroglycerin, you understand the nature of the drug is to cause vascular dilation. And it's going to cause it not only in the coronary arteries, but also in the periphery. So we're going to have increased blood flow, possibly moving a clot, will restore oxygenation to the affected tissue, but also it's going to cause a decrease in systemic vascular resistance, which will drop blood pressure. So our indications are met, our therapeutic effects are met with relief of chest pain because we have reperfusion through the coronary arteries, but also the side effect is the drop in blood pressure. We can continue to give nitroglycerin if the patient still has chest pain. Now we have other types of responses, these adverse effects, where the clinical changes are not desired and can cause harm or discomfort. So whereas drop in blood pressure is not so much an adverse side effect, it is a side effect all the same. You're not really using nitroglycerin to drop blood pressure, but dropping blood pressure puts less of a demand on the heart, the resting pressure lowers, and that actually can help a diseased heart, sure. But another drug we give, epinephrine, in anaphylaxis, it has adverse side effects. It's a profound, strong beta agonist. It's not specific to beta 1 or beta 2. It's going to hit every cell that has a beta receptor on it. And it's going to send a pronounced message that is prolonged. So that's good for our targeted cells, which are the smooth muscle cells of the bronchioles, which will cause bronchodilation and combat the swelling that is the clinical sign of anaphylaxis of the bronchioles. But also it's going to cause cardiovascular changes, increased heart rate. That can be adverse. An adverse side effect is making the heart too excitable and causing it to go into VFib. So the severity could be from palpitations to VFib for this. So it can be mild to life-threatening. In some instances, it can be desirable, but in others, it's harmful. An example of desirable effects of tachycardia in patients would be neonatal resuscitation. Increasing the heart rate is your goal. And that's why at the very end, you're going to be given epinephrine if nothing else works to stimulate the heart. Right? Now, that's not something you really want to do in anaphylaxis or asthma treatment, but that's the targeted effect at that point. In addition, there can be unexpected or idiosyncratic reactions. Something that has never been seen before, was not expected. It can be, by idiosyncratic, mean unknown. So you have to be aware of everything. Anytime you give a drug, you have to be aware. You administer medications, you thoroughly assess and reassess your patient. It's why almost every state has a protocol in place for ALS. It says when you administer medication and the patient doesn't want to go to the hospital, you have to get clearance through medical control and they must be given informed consent. The reason is we don't know. We've just administered medication. We don't know what's going to happen to this patient. Now generally we have that index. We have the therapeutic index based on all of those clinical studies, the trials with both animal and human that show the levels of toxicity. The mean lethal dose is what killed 50% of the animals tested. So they'll determine the lethal dose if half of the animals tested died from that accelerated or elevated dose. Median toxic dose, 50% of the animals tested had toxic side effects of the drug. So the median effective dose is the bottom. So when you're talking about the therapeutic index, you want it, the bottom is the median effective dose and the top is the median toxic dose. So you want to fall right between those two, the bottom and the top. And that's known as the therapeutic index. Now, what drug companies are hoping for is a very large difference. You know, the bottom is low and the top is extremely high. That makes for a very safe drug. You can administer it in different doses and not worry about toxic issues. A small difference, like we see, I mentioned before, giving Coumadin, a very narrow window, patient needs to be monitored. Blood work drawn. You know, we see this a lot with our the drugs that are administered for people with seizure disorders, and how the median levels can drop. It can drop below the therapeutic threshold, and the patient can begin seizing. You give too much of the drug and they can seize again. So you want to maintain blood work. A lot of epileptics have to go in for monthly, sometimes weekly blood panels to see what their drug levels are. We want to maintain those therapeutic levels at all times. Now, sometimes we give a drug and we have an allergic reaction to it. That's medication sensitivity. The body reacts to it as an invader. It activates the humoral immune system, and through antibodies and histamine secretion create the allergic response. Patients know when they're allergic to a medication. It's based on history. Can you give medication to somebody the first time and then they'll have a systemic allergic reaction to it? Absolutely. It's part of your reassessment findings. If you know that an allergy actually exists, then this is a situation where it's a relative contraindication, especially if there's an issue with life-saving, and that has to be addressed with medical control. Medication tolerance, well, you have a breakdown of the receptor sites, and as a result, you build up a tolerance in your body because there's not as many receptors stimulating. So it's going to take more of the drug to have the same therapeutic effect. There's another thing called cross tolerance, where you're on one drug and it will allow you to be more tolerant of the other drug. Doctors who specialize in allergies do something known as tachyphylaxis as part of their treatments, where they give repeated doses of a substance over a period of time, and it can actually reverse some of the effects of allergic reactions. But medications that are overused outside of the prescriptions, or even within the prescription boundaries, can cause dependency. These drugs prone to misuse and abuse are stimulants and depressants, things that will have an effect on the neurologic center. Repeated exposure, of course, makes habituation, and prolonged significant exposure can cause dependence of the drug, where the body will no longer produce its natural supply. It waits for the artificial, the exogenous supply to be provided. Medications interact with each other. You have undesirable medication interactions, like patients who are on erectile dysfunction drugs getting nitroglycerin. Most states and regions look at a 72-hour window between when you took that Viagra or whatever other type of erectile dysfunction drug and getting nitroglycerin. Once again, talking to a physician and getting approval for nitrates is a case by case. Giving medication, as soon as you give it, the body starts disposing of it through its network of enzymes. The way that the drug should stay in the body is determined by how much of the drug you've given, the route it was received, parenteral versus enteral, and the patient's hemodynamic and homeostatic stasis. What's their physiologic state right now? Are they unconscious? Are they diseased? Are they in shock? Different things can have effects on the way the body can eliminate drugs. So pharmacokinetics, when we're talking about a medication profile, we're saying the onset is related to absorption and distribution. Okay? When the drug is when you first start seeing effects on the body. Peak effects is when you are at the highest point. And this is measured by time. Onset, peak, and duration, all measured by time. The route that it's brought on is absorption and how it got into the body. The bioavailability is the amount of the unchanged medication that reaches systemic circulation. And once again, this alters not only by the route, but also the type of medication. So, for instance, if a drug is taken in by enteral route, it goes through the hepatic portal system and is digested with the rest of that same process. It's broken down by pancreatic enzymes and the acids of the stomach and the alkaloids of the liver, and it starts the breakdown process in the GI tract. Then it gets sent up to the liver, and the liver will start to filter it out and break it down. So before it reaches the body, it's not as effective as it would have been if you had given it parenterally or like IV, 100% bioavailability. So the availability alters by the route that is given. In order to administer medications orally or through oral gastric or nasogastric tube, patients should, well, they need to be conscious in some instances. They must be able to swallow. And if they're unconscious, having a nasogastric or an orogastric tube it avoids the oropharynx and possible aspiration. Endotracheal administration of drugs is no longer in favor. It's the least popular parenteral route of administration. Understand that you're going to give it, its bioavailability changes. A lot of the drug gets trapped in the alveoli, won't diffuse across the alveoli space into the capillary beds. So it's not as effective. As to combat that, we have to give double the dose, and then we have to flush it with 10 to 15 cc's of fluid, and that has been shown to cause ventilation perfusion mismatches because we're putting fluid into the lungs. We want to keep our ventilation perfusion well matched, even in cardiac arrest, as best as possible. Intranasal is accepted because it doesn't go into the lungs, it's absorbed in the nasal mucosa. Bioavailability is almost as good as IV and IM. It's rapid, and there's no risk for needle stick injury. The preferred method of medication administration is intravenous because of its bioavailability percentage. And it's rapid onset. But it's limited. You need to do the procedure. You got to start an IV. What if you don't have time for that? What if you can't get an IV? What if you have a patient with poor resting blood pressures and the veins have collapsed, like you find in cardiac arrest? Then we think about interosseous. Interosseous is a rapid procedure that works more effectively sometimes than intravenous. You can leave the needle in place for up to 24 hours, but there are contraindications, bone fractures, issues with the lower extremities. And you see all the different types of approved interosseous sites. You have it on the proximal tibia, which is very common, the femur, the distal tibia, medial malleolus, the proximal humerus in the arm, and the sternum. These are all FDA-approved methods of interosseous medication administration. Some of them come with different challenges. For instance, giving an interosseous injection into the sternal wall can have a problem with chest compressions. Other routes we have, parenteral, intramuscular. See, the bioavailability can shift depending on muscle mass and disease processes, patient-specific. All right, know that it's appropriate for IM use, and know your maximum amount of fluid you can put in there. And rule of thumb is it's 3 cc's that can go into the muscle. Subcutaneous goes into the subcutaneous space. 1 cc is the maximum. It's much slower in absorption. Bioavailability is about the same as intramuscular. Dermal and transdermal, depending on the type of medication. Some medications can't be given transdermally. Others are. Nitroglycerin for one, nicotine for another. Sublingual is another good route for nitroglycerin. It goes under the tongue. The oral mucosa absorbs a lot of different products, and aspirin is one, nitro, and sugar. Inhaled nebulized, we need, of course, oxygen, and patients will have, without oxygen, they will have the meter dose inhalers, or MDIs. But realize that if there's a reaction to either the drug or one of the preservatives of the drug and you inhale it, it can cause immediate bronchoconstriction. So once again, be aware. Just don't make assumptions when you administer medications. Rectal, some drugs are preferred that route. Valium comes to mind when we talk about rectal drug administration. You can see it has a much better bioavailability than through IM sometimes. But understand that absorption can be unpredictable. You may not know that you've given the right amount. It can be a problem. You can also lead to a toxic level of the drug, so be careful. Ocular anesthetics are given through the sclera, and that's your pain relief drugs that you take, that you administer for chemical burns to the eyes. Other methods we have hemodialysis, where the blood is filtered through a machine, and we think more about parenteral. I always say we go parenteral because we're paramedics, but we only go through the approved routes. And up until about 6-7 years ago, IO was not an approved route for adults. Now it is. So technology changes. This is why we refresh, make sure that we're current with our medical procedures that is specific to the region and agencies we work for. So how we distribute this medication is determined by, well, the medication itself, its physical properties, and patients. Different types of issues with patients, their underlying medical state, their current physiologic state, shock, unconscious, hyperactive, hypermetabolic. And there are systems of barriers that will prevent foreign particles, including your drugs, from entering into the body. There are scientific rules of homeostasis, the way we normalize. We have diffusion and osmosis. When we're talking about diffusion, we're talking about particles going from an area of high concentration to an area of low concentration. We're talking about osmosis, now we're talking about fluid. The redistribution and the balance is all part of that filtration process. And as we build up pressure in the vasculature, let's say, that's known as hydrostatic pressure. It's either in the vasculature going into the interstitium, the cells, or the interstitium pushing across into the intravascular. We try and have continuous barrier cells that protect vital tissue, and these are mostly the squamous cells that you find that are on the inside lining of vessels, like the arteries, and these squamous cells, or the trachea. These squamous cells actually they're protective, and they're like the tiles on space shuttle belly or pawns on a chessboard. They can be replaced. We don't really care about them that much. They get broken down. They take most of the trauma, and then they're quickly replicated, and the shield goes back up. But what happens with these epithelial cells, when they're in place, they provide that barrier. So if you have a large ionic molecule, it's got to be able to get across. Now, one big example of a large molecule that can't make it across into the cell is sugar. Glucose is so big, it can't make it across. It needs to have a hormone that can alter the structure of the cell membrane to allow it to pass through, and that hormone is known as insulin. You find these barriers for sugar, the blood-brain barrier, the blood-placenta barrier, the blood-testes barrier. That's a big issue, and they need hormones to alter their permeability to allow for shifting across. We have a plasma protein binding. This is where molecules that make up the medication attach to proteins in blood plasma. So concentration of these plasma protein binding agents will be affected by levels of the protein in the blood, or another medication that binds with it is introduced. So it has an effect based on the other drug. Drugs are out there, the statin-based drugs that break down lipids in the, or fat cells in the bloodstream are in favor, are really the big drug that's, there were studies saying that it's being overused, and really diet and exercise can lower your lipid panel levels than just giving this statin type of drug. But that's what a statin does, is it drops lipid levels. It's released slowly and it has prolonged effects, and that's what's really under attack now, where it's being overused instead of as a last ditch effort if diet and exercise are not working to lower our lipid count in our blood. So when we're talking about volume and distribution, we're describing the extent that medication can actually make its journey and spread across the body. When you have higher levels present in plasma, you just need to have lower volume of the drug. So this is all part of the testing phases in the lab, finding out how it's able to be distributed. And then once it's done in the lab, then we test on animals. This is the whole purpose of different drugs can distribute quickly or slower based on the body's ability to break it down, the way it can transport it, has a whole different myriad of things. But this is why it takes so long for drugs to actually be approved by the FDA. When we're talking about breaking drugs down, that's biotransformation. And drugs have what are called half-lives. And a half-life is how many minutes it takes for the drug to be half effective than it was before. So the way it breaks down is it goes 1/2, and then half of a half is a quarter, half of a quarter is an eighth, half an eighth is a 32nd, I'm sorry, is a 16th, half of a 16th is a 32nd. Once it reaches between 1/16th and 1/32nd, it's now an inactive molecule. It's no longer, it's lost its efficacy and its ability to have any type of cellular interaction. All right, so there are some drugs that have a very fast half-life, like epinephrine has a 3-minute half-life. So in 3 minutes it's working at a half, and then in 6 minutes it's working at a quarter, and then in 9 minutes it's working at an eighth, and then in 12 minutes it's working at a 16th. So it breaks down quickly. Now, amiodarone has been shown to have a half-life in some instances of 32 days. 32 days. That means that in 90 days, it's only working at a quarter of what it was when you administered it 3 months prior. So you can see how biotransformation can alter with the drug itself, not just how the body handles it. Other effects of biotransformation. Mostly we're talking about how the body can break things down. Sometimes a body can break down a drug and rapidly eliminate it from the cardiovascular system. And when we talk about a quick way the body can get rid of something, it's still effective but out of circulation, is THC. THC in marijuana. The body takes it and doesn't break it down so much as it stores it in fat. Other types of drugs are able to go quickly out through urine. So the kidneys will not let it come back up. And controlled substances and habitual drugs like opioids and cocaine will have a 3 to 5 day period where they're in the blood. Where they're in the urine, but they get kicked out really quick through the urine process. Whereas with THC, it stays active since it's being absorbed by fat much longer, sometimes 2 weeks to 30 days for habitual users. It will stay in positive findings in urine. So most biotransformation is going to occur in the liver. Okay, and there's something known as the P450 system, which changes the chemical structure of medication and starts breaking it down. But in addition, like I talked about with the kidneys, we have the skin sweating out, lungs breathing out, the GI tract excreting, and other tissues can, like fat creation, can cause this biotransformation. In the kidneys, we have the zero order elimination. So the substance is removed during a certain period, and that's that window for drug testing. That half-life that I discussed, 50%. How many minutes goes 50% of what it was before? Things that can change the way the body can break down and affects half-life is the patient's disease state. Are they hypoperfusing? Do they lack the ability to have that enzyme to break down that drug? And then other medications can interact to change the potency of the drug where it makes the half-life much longer. So the best way that the body can eliminate drugs, we use the buffer systems, respiratory and renal. And that takes a long time. So we have to remember that we're giving a medication to a patient that can have lasting, if not permanent, side effects, including death. So errors need to be avoided as best as possible. And remember your 6 rights. Is it the right patient? Based on your history. Is it the right medication? Is it the right dose? Is it the right route? Is it the right time to give the drug? Okay. Have you given this drug with another drug? Should we wait for that other drug to work before we consider this drug? Case in point, morphine administration and chest pain. Have you resolved the chest pain with nitro? Have you given the nitro enough time to work before going to morphine? Are you aware of the side effects that morphine can give? So this is the right time to do it. And then, are we documenting correctly? And when we say correctly, we also have to add honestly. Errors happen. Making sure that the hospital you're signing the patient off to understands that you made a med error and you document correctly is vital for overall patient care. If you withhold that knowledge and you've overdosed your patient or given them an improper medication, and then in the hospital they give another medication that potentiates the drug that you gave, you can kill your patient. I always say it's not the crime, it's the cover-up. I've been an administrator for a long time, and I've always said that. Med errors, I want you to be honest. I would rather you were an honest person who made a mistake than a medic who lied to look like they didn't. When we're talking about proper documentation, not only does it have to be thorough and accurate, but it has to be universally acceptable. And the Institute for Safe Medication Practices has developed a list of error-prone medications. And if you do a Google search for IMSP, they can show you a listing of all the accepted abbreviations, because some abbreviations can mean multiple things. So when you're in doubt, write it out. For instance, you look at MSO4. MSO4 is morphine sulfate. But MSO4 looks a lot like MgSO4, which is magnesium sulfate. So you want to avoid this? Write out the word. Write out magnesium sulfate, morphine sulfate. Especially if it's a controlled substance. IN in a written form can look a lot like IM. So write out intranasal. And we always use something called a trailing zero. So there should be a zero after everything. So if you want to say 0.8 milligrams, it should have as a 0.8. Just so they see that trailing zero and say, all right, so that there's a point there. Because it could be looked at and seen that instead of it being 0.8, it's 8. Okay, so understanding medications and how they break down the body in different ways, and the understanding that some will have prolonged, if not permanent, side effects, we have to be very cautious in administration. And that only comes through a thorough patient care interview, assessment, diagnostic findings. Medication should be the very last thing that you're doing. So let's look at some of these classes of meds. Our sedatives, or hypnotic agents. Autonomic. It's a single dose, profound sedative. It works by acting on chloride channels in the brain. Minimal effect on blood pressure. It starts working very quickly, and it dissipates rather fast too. Of all the sedatives, it's the fastest. So if it's given and you want prolonged sedative effects, then you need to back it up with other hypnotic, like a benzodiazepine. Other sedatives out there, ketamine. So ketamine, autonomate, these are great sedative agents when we're looking at airway management. Realize that unlike autonomate, ketamine has been shown to raise intracranial pressure, so it's not indicated for certain patients, head injury that require airway maintenance. Benzos are potent anti-seizure sedative agents. They're Class D pregnancy relative contraindications or precautions. It could be potentially harmful to the fetus, so you need to use caution when administering this medication to a pregnant patient. Now, once we've sedated the patient, and now we want to paralyze them. Okay, we have, when we administer paralytics, they block muscular tone and the ability to send pain reception. So it antagonizes the acetylcholine receptors. You can see acetylcholine coming off the nerve endings, the axon, to the targeted muscle fiber. It locks on to the receptors, which cause an opening of the sodium channels, allowing sodium to diffuse across, and you have muscular contraction as a result. Now, you give a paralytic, it's going to, you see it pictured in blue on the right slide, it's now going to compete for that receptor and block the acetylcholine from locking onto it. When it gets onto the receptor, it does not cause the sodium channels to open. We have two types of neuromuscular blocking agents. We have our fasciculating and we have our non-fasciculating. The only drugs out there is the succinylcholine that causes fasciculations. This is known as a depolarizing paralytic. It's rapidly brought on and it has a brief duration, so it's a good drug to initiate that paralysis of the diaphragm. So they're unconscious and now they've stopped breathing as a result. There are some adverse side effects, and this is why you need to study its indications. It's bad for patients who are hyperkalemic. You might see that with burn patients. Bradycardia, elevated intraocular pressures, malignant hypothermia, head trauma in some cases. So you need to know the whole history before you administer this drug. Now the non-depolarizing agents, now we're talking about longer lasting, and you don't see the muscle spasms or fasciculations that you would see with succinylcholine. So this is done as a backup for that short-acting, fasciculating, depolarizing agent. So this non-depolarizer is much longer. And you have the rocuronium and vecuronium. Any drug that ends in ONIM is an NMDA. When we talk about being able to affect smooth muscle of the bronchioles, we have drugs that are corticosteroids, anti-inflammatories, vasoconstrictors, and bronchodilators. These are beta agonists, very, very common. We have the selective and non-selective. Okay, the selective like albuterol, the non-selective like Alupent. There's actually another level of albuterol called levoalbuterol, which is less beta-1 effects than albuterol itself. Other drugs are out there, terbutaline and epinephrine. These are more beta-specific, more beta non-specific than the albuterol and levoalbuterol. Drugs that are given in conjunction with albuterol are the mucinetic agents like ipratropium. It antagonizes the muscarinic receptors, which causes bronchodilation and decreased mucus supply, mucus production. It puts somebody it blocks parasympathetic tone, that feed or breed mucus production process of the parasympathetic nervous system. And then it flips you into sympathetic, because parasympathetic is blocked, sympathetic becomes the dominant. Corticosteroids are anti-inflammatories. Realize that they do have, because they're anti-inflammatories, they get in the way of the inflammatory process of the immune system, so they have immunosuppressant properties. There are adverse effects that come with that in an immunosuppressed state, so you have to use caution with corticosteroids. Drugs affecting the cardiovascular system, now we have our antidysrhythmics, and they will resolve dysrhythmias by different methodologies. They suppress different focal points, and they break them down to the Vaughan-Williams classification group, and there are 4 phases, so 4 levels. Now, just to review cardiac activity, the 4 phases of the cardiac cell is it's an involuntary skeletal muscle cell. So it works just like skeletal muscle, but it can do it involuntarily without knowledge of the somatic nervous system. It's under autonomic nervous system control. So phase 4 is the period when cells are resting. And phase 0 to 1 is very quickly. Sodium channels open, sodium rushes in. Now the property of sodium, it's positively charged. Okay? Positively charged sodium is rushing in. And what that's doing is raising the polarity of the cardiac cell. It's getting more positively charged. As it's going from 0 to 1, the sodium ions come rushing in. And as we enter into phase 1, at the top, sodium is decreasing and potassium slides out. At phase 2, calcium moves in, and that's when we have that depolarization. We're starting the process of depolarization. It starts first with electrical depolarization. And then maybe a nanosecond later, we have mechanical depolarization when the microfibrils twitch. We reach a certain level of polarity that will cause a twitch to occur, a depolarization. Phase 3 is the end result of this depolarization, and now we're going to start the process of repolarization. Repolarization, you see all that potassium that left? Let me just go back a slide. See all the potassium that left? We got to get it back. See all that sodium that's in the cell now? We got to get it out. So how do we do that? Since the potassium went out because there's less potassium outside than inside the cell, and sodium went in because there's less sodium inside the cell than outside, we're working against the grade of diffusion. It's going to require an active transport process And that's the repolarization. The sodium-potassium pump is operating. That's why it's a little more prolonged, the repolarization cycle. And it expends the most energy. So when we're looking at different drugs that affect these phases, these 5 phases of the cardiovascular, the cardiac cycle, we want to try and work on those channels. Class 1 antidysrhythmic slows the movement of sodium into the cells. So those fast channels open, sodium rushes in. In an overexcited heart, or a heart that's not given enough time to repolarize, and they suddenly go back in through a signal sent by the SA node, you can cause the heart to have that R on T phenomenon and go into VFib. So you want to reduce it, so you give this class 1, slowing the sodium channels. Procainamide suppresses the ectopic foci and slows the conduction. Lidocaine actually blocks the sodium channels. Class 2, we have our antidysrhythmic beta-adrenergic blocking. So class 1 is sodium channel blockers. Class 2 are beta blockers. An example of a beta blocker is metoprolol, otherwise known as Lopressor, labetalol. Any drug, generic name, ends in OLOL, is classified as a beta blocker. And these are class 2 cardiovascular drugs. Class 3, these are antidysrhythmic medications that prolong the absolute refractory period. So by doing that, it slows conduction. It works with calcium channels and potassium channels, not just sodium channels. And that's where cardarone is. Cardarone's at class 3. It's something that will affect all the channels, so it slows down every phase of the cardiac cycle. Class 4 is specific calcium channel blocker drugs. So when you're talking about specific to calcium channels, now we're talking about drugs that affect the internodal pathways, the sinoatrial node and the atrioventricular node. Because those nodes, their trigger mechanism that causes them to send the impulse, or the actual pacemaker, is calcium channels. So you want to slow down your atrial rate. You have atrial fibrillation, you have atrial tachycardia, you have atrial flutter. You want to give these calcium channel blockers, like verapamil, like cardizem. But realize, if you're slowing the pacemaker and the cardiac conductive system, there are some profound side effects that you got to be careful of, like, I don't know, asystole for one. Okay, so having consistent cardiac monitoring is vital. So finally we have those are the 4, and now we have our unnamed class. And the unnamed class, the big drug that's in there, is adenosine. Why it's unnamed? Science is not really sure of its actions. It just works on the AV node by ceasing activity on internodal pathways. And it's rapid onset and brief duration. So of course, when you give adenosine, this is why you flush it. Additional cardiovascular medications, we have alpha-adrenergic receptor antagonists. So where do you find alpha receptors? Smooth muscle of the arterioles and the venules. So patients who have chronic constriction of those arterioles, those arteries, will end up with an increase in systemic vascular resistance, which plays a big role in elevating diastolic pressure, that's your resting pressure of the heart. So you want to reduce the internal pressure of the cardiovascular system by dilating and reducing the constriction of the vasculature. So you lower your diastolic, and in that respect, you lower your systolic. It's a great way to combat hypertension. There's different types. You have catapress, which is an alpha-2 receptor agonist, Regitine, which is a subcutaneous injection. It reverses vasoconstriction in tissue. It's a critical care medication. We give labetalol for hypertensive crises. It's a good alpha, beta, and beta-2 antagonist. Here's the problem with labetalol. Would you give it to an asthmatic? I wouldn't, and here's why. If the patient suddenly starts wheezing, the albuterol that I give is not going to have any effect. Why? Because beta-2 receptors have been blocked. Now we have other drugs known as ACE inhibitors that work with the negative feedback mechanism known as the renin-angiotensin negative feedback loop. So how does this work? The kidneys are always monitoring blood pressure, and when they end up seeing what they deem to be less fluid going into the kidneys, they'll trigger a hormone called aldosterone. Aldosterone will trigger renin in the adrenal glands from being it'll cause renin to be secreted. Renin will trigger the creation of angiotensin 1 hormone. So angiotensin 1 has no effect on the body. Angiotensin 1 starts getting broken down, biotransformed, by the angiotensin converting enzyme into angiotensin 2. So at the first pass, this drug turns from angiotensin 1, breaks down to angiotensin 2. Now angiotensin 2 has an alpha effect on the body, causes vasoconstriction. So it's how the kidneys combat what they perceive to be dehydration. Patients who are chronically hypertensive and are stuck in this negative feedback loop, they are given a drug called an ACE inhibitor. It prevents that angiotensin converting enzyme from being produced, and as a result, angiotensin 1 can never become angiotensin 2 and have a clinical effect on the body. Now this is an issue because we're getting in the way of the normal processes of the body, the way that they produce enzymes. So there are side effects that patients can have angioedema, sudden swelling, the patient can have an untoward reaction. Vasodilation can cause the capillaries to become more permeable, or sorry, less permeable, and allow fluid to shift across. So they're given by physicians, they're not given in the emergency setting. ACE inhibitors are given more as a chronic medication, and the patient, of course, is followed up during this to make sure that none of the other issues are kicking in. Now, some emergency medications we give have an effect on the autonomic nervous system. And the autonomic nervous system is broken down into the sympathetic and the parasympathetic. And drugs that we give will either affect the sympathetic, affect the parasympathetic, or block them. And when you block one, the other one kicks in. So atropine is a muscarinic receptor antagonist. And what that means is that it blocks the receptor sites of the parasympathetic nervous system. And as a result, sympathetic tone will kick in, be more pronounced. It's good treatment for bradycardias because sympathetic tone increases heart rate. Atropine is used in different ways. In addition to its cardiovascular issues for treating symptomatic bradycardia, it also has a role in airway management of children because manipulation of a child's glottis can trigger a vagal response. And the vagus nerve controls the parasympathetic nervous system, and when it's triggered, the child will go bradycardic. So a lot of systems will have you prep the patient with atropine to block that vagus nerve stimulation. In addition, it's given as part of your Mark II injection kit for nerve agent toxicity. What do nerve agents like VX and sarin gas, the G series of, what do they do? How do they kill you? How do they cause that sludgium effect? Well, they destroy acetylcholine esterase. Acetylcholine esterase is the enzyme that breaks down acetylcholine, and acetylcholine is, in addition to the neurotransmitter of the musculoskeletal or somatic nervous system, it's also the neurotransmitter of the parasympathetic nervous system. So when you destroy this enzyme, there's no way to get the acetylcholine off of the receptor sites, and what we end up with is an overstimulation of the parasympathetic nervous system. So when you give a Mark II kit, what are you doing? Well, the atropine is blocking parasympathetic tone. But more importantly, the 2-PAM, the prolixinone that you administer, preserves acetylcholine esterase. Because once you destroy all your acetylcholine esterase, it can't be manufactured again. And this is where patients end up dying. They get the salivation, lacrimation, urination, defecation, GI disturbances, emesis, and they'll have the muscular contractions, and they'll have bronchoconstriction. The real thing that kills them is the bronchoconstriction. They suffocate. So it's a horrible way to die, and we want to prevent it, and there's no way out of it once all the acetylcholine esterase is gone. So given that Mark I kit, and now it's Mark II, is vital for not only their care, but your care if you find yourself to be exposed to a nerve agent. Catecholamines, what do? Well, they are sympathomimetics. They stimulate sympathetic nerve tone. There's natural catecholamines like epinephrine, and then there's sympathomimetics, things that mimic sympathetic tone. Like albuterol, like amphetamines. Okay? The thing with these sympathomimetics is that they're longer lasting than their indigenous counterparts, like epinephrine and norepinephrine, because the body doesn't break them down as readily as they would these indigenous hormones. So epinephrine catecholamine stimulates alpha, beta 1, beta 2. It's the primary neurotransmitter of the sympathetic nervous system. You can give it all different ways. Understand its beta 1 and alpha qualities are dangerous. Levofed, norepinephrine, is a primary beta 1 stimulus. So when are we going to administer Levofed? In profound bradycardia, cardiogenic shock, in a way to restore blood pressure. Another way to restore blood pressure is through use of inotropine known as dopamine. Dobutamine is a synthetic dopamine, and while it was in the pre-hospital setting, it's fallen out of favor from a national perspective, but you may still have dobutamine on in your protocols and on your regs. Now, a synthetic alpha agonist is a drug like phenylephrine, otherwise known as neosynephrine. It's a potent vasoconstrictor. That's why you give it for stuffy noses. It dries up secretions. But understand that it also, why it's not really in favor over the counter anymore, it causes profound beta stimulation, beta 1 specifically. Vasopressin is a naturally occurring hormone stimulated by the pituitary gland, and it handles issues. It causes profound vasoconstriction, which is useful with GI bleeding, the dilation that occurs there, diabetes in addition, shock, and it's a first-line drug for cardiac arrest. Now we talk about, those were the vasoconstrictors, the catecholamines and the sympathomimetics. Now we talk about the drugs that affect vasodilation, and this is used for uncontrolled hypertension, congestive heart failure, and can be used for all different methods of things. So nitroglycerin is a vasodilator. It's pretty safe and effective, and it's been a lifesaver over the years. And there's different ways that you can administer it: sublingually, transdermally, and in stronger cases and more maintenance dose, IV. Of course, you want to make sure that there's no interaction with drugs that are used for erectile dysfunction. Other drugs given in hospital, you might see on our critical care transport: sodium nitroprusside or nipride. It's given IV. It's a profound vasodilator. What's great about nitroprusside is, nitroglycerin has a short half-life, but you shut it off, it's still working. With nitroprusside, you shut it off and it almost immediately stops working. So it's a much better drug to give as maintenance. If the blood pressure suddenly drops, you can cease dripping it and you'll restore hemodynamics. Hydralazine is an arterial dilator, right? So it's effective to lower pulmonary and systemic vascular resistance, or diastolic pressure will drop. In an emergency setting, you give this medication over at least a minute, and you got to wait because it has a long half-life and you can't repeat it right away. Usually the effects will start to wear off after about 25 to 30 minutes, and that's the time when you want to evaluate your patient and possibly re-administer. Diuretics, these are drugs that affect the kidney's ability, the nephron, from drawing fluid back into the vasculature. That you see a lot, that's in the tubules, the descending tubule, the loop of Henle, the ascending tubule. Furosemide is a loop diuretic. Just understand that when you give furosemide, it works because it prevents the body from reabsorbing sodium. And if it doesn't reabsorb sodium, then water stays there because water follows salt. And what happens is you drain the patient out. Sure, you get excess fluid out, but now they're hyponatremic. You have to be very careful using this. Mannitol is more of a diuretic for brain function. It reduces intracranial pressure with cerebral edema. Things you're going to start seeing now on ambulances, especially during critical care transports, are blood product administration. Now, we know that the average adult has about 5 liters of blood. That makes up between 7 and 8% of body weight. When you have issues with absolute blood loss through hemorrhagic shock, this is when you need whole blood replacement. Relative hypovolemia, we're talking about anaphylaxis, cardiogenic shock, sepsis. You don't require blood replacement. There's enough blood, but the pipes have actually opened up so much that blood pressure has dropped. That's relative hypovolemia. We're talking here about exsanguination, absolute hypovolemia. So blood products that you find are either type specific, meaning they are O negative, RH negative, RH positive. Or they're cross-matched. Cross-matching can take a while, about 30 minutes to 45 minutes on average for a lab to come back and get a proper type and cross. So it's given mostly in ICUs and in some trauma centers. If you don't have time, the patient is in decompensation, you can sometimes give unmatched blood. You don't have to know what the patient's blood type is. Your blood type A, what is his RH factor, is it positive or negative as in terms of antibodies. So you want to find that out. That's obvious. The best way to go is the cross-matching and getting a type-specific blood. But you can give unmatched blood. Unmatched whole blood, we're talking about O negative. O is the blood type, and the RH factor is nil, 0, negative. So O negative blood that's why it's known as the universal donor, people who are O negative. If you know your blood type and you're O negative or AB positive, you're getting calls from blood banks constantly. If you don't know what blood is being given as part of your transport decision, you got to find out, is this a cross-matching or is this an unmatched? Remember, when you're giving unmatched blood, it's not specific to the patient, so the higher probability of actual transfusion reactions occur during the unmatched transfusion. Some of the side effects you're going to see, you will see profound hypotension, and in some cases urticaria and tracheal swelling. So you have to be aware. If you have a patient with a urinary catheter, look for changes in urine color. You may be bleeding internally. Temperature, one of the first signs that you're having a reaction to blood administration will be a sudden change in temperature. So that might be part of your transport protocol. And there's different types of ways that we can administer blood. And I described whole blood, which is just donated blood that's been filtered, but is everything. It's plasma and all the elements put together. Now we have other types of blood products that take components of the blood and make them an actual product, like packed red blood cells. Packed red blood cells, they take out all of the platelets, they take out all of the other formed elements and proteins, and they just have them in like a plasma type solution, packed tight together. So these are for patients that have adequate blood volume, but they don't have enough red blood cells to meet the requirement of 5 million per cubic millimeter. Drop below that, you're diagnosed with anemia. These people get packed RBCs. A unit of packed red blood cells will have between 225 and 250 cc's of concentrated red blood cells. So patients who get this, there could be an issue of volume overload. The body might try and compensate by shunting fluid, shifting it from the interstitial spaces in the cells and the tissue into the intravascular region. So you have to be careful. Don't give it longer than 4 hours per unit. And this is in a solution that is hypoallergenic. It's a citrate-based preservative. But understand that you can have issues with electrolyte imbalance. So what are you going to see with things like hypocalcemia? You might see some bradycardia. Hyperkalemia, you might see some profound T waves, some peak T waves. Fresh frozen plasma is when you give this for patients that are unable to clot effectively. FFPs don't have to be RH compatible. They don't have that RH, that rhesus antibody located. And units hold, up to 250 cc's, and they need to be defrosted before administration, and there's different ways that hospitals can defrost them. Once again, rarely we find these on your ambulance, long distance transport ambulance or a helicopter. This is something that is going to be prepared at the hospital. There's a chemical called cryoprecipitate, which is the new type of fresh frozen plasma, and it is given to patients with hemophilia, and it is actually much more effective than fresh frozen plasma. And understand that unlike FFPs, which is more of a generic, cryoprecipitate is a drug that is, it's a product that is specific to blood type. So patients on this, it's much more effective than fresh frozen plasma, but it's got to be specific to the patient's blood type. And what it contains, I'll just go back real quick. So what cryoprecipitate contains, just like fresh frozen plasma, it has all of the important factors for clotting that people with clotting issues lack. And some of the important factors that it has is like it contains fibrinogen, it contains the von Willebrand factor, the VWF factors, and factor 13, which are an important part of the overall clotting process. Platelets are given for patients who are unable to produce enough platelets. Your platelets count should be between 150 and 300,000. You fall below that, then you're suffering from something called thrombocytopenia. Platelets need to be specific to blood type and RH compatibility. So that's a way that we can restore proper hemostasis, the ability to have all of the proper formed elements in the blood. So we understand the process of clotting. It's done in conjunction with that clotting cascade that I mentioned, with the different factors. Factor 13 very important, factor 8 being very important. The creation of fibrinogen, which is the web of protein that other things get stuck on, including platelets, and they make a thrombus. Now, sometimes that's a good thing when we're dealing with trauma and rupture of a vessel, but it can be a bad thing when it's misread and the body sends the wrong reaction to an injury site. They read it, instead of a inflammation, they see it as a breakage. And you see that happening with patients who are having myocardial infarctions. The clotting occurs at a narrowing of the coronary artery, where the genetic predisposition, where the body misinterprets the chemical signal or prostaglandin sent out by the irritated smooth muscle in the medial layer of the coronary artery that's saying, help, I've got reduced blood flow. They see it as a breakage. So they send the wrong response. It includes the clotting cascade and platelets. So what we end up with is a clot at the narrowed part of the coronary artery and distal restriction of blood flow, and now we have tissue necrosis. So how do we stop that? We got to give an antiplatelet. What's a very potent antiplatelet? Well, we can give is aspirin, but we also deal with the coagulation issue. And one of the big coagulation, we want to stop that blood clot production. Heparin and Lovenox are big drugs that stop the clotting process. The antiplatelet medications we have, so there's no new thrombus to create. It blocks the body's ability to interpret that prostaglandin that's being released and cause an inflammatory response. So aspirin, probably the oldest drug that we have in existence. It was invented by Hippocrates back in ancient Greece. But we also have Plavix and Tyclid now, which are new drugs. We also have the new glycoprotein 2B, 3A inhibitor medications, which are given post-STEMI treatment. Post-MI patients receive this, and this builds up a base level where there's no platelet aggregation or reduced platelet aggregation. Fibrinolytics dissolve fibrin. So it's kind of like the liquid plumber of the cardiovascular system. Understand that it's not specific to the fibrin that you're looking for. It's going to destroy all fibrin. So patients with bleeding disorders, patients who are involved in trauma, these are patients who are contraindicated. And before you give fibrinolytic, if you give it in your system, there's a checklist that you have to do. A lot of times we find out things like, was the patient ever in cardiac arrest in the last 3 months? Were they a victim of trauma? They have GI bleeding? Anything that can cause more bleeding with giving this fibrinolytic, like streptokinase or TPA. Now, moving on to the neurologic system, we have our analgesics, which stimulate opioid receptors to relieve pain. They've been known to cause tolerance, cross-tolerance, and addiction with overuse. They cause, in addition to pain relief, they cause profound sedation and respiratory depression, because they work just like heroin in that respect, where the body can't really monitor itself. It's in such a sedentary state that it's unable to monitor brain activity. Unlike benzodiazepines that deaden the brain cells by allowing chloride, negative ions, to go in and deaden the overall polarity of the brain cells. These analgesics actually disrupt dopamine response. So that has a way of not just, it doesn't change the polarity of the cell, but it changes their ability to function correctly. Some common medications, analgesics that we give: morphine sulfate, of course, fentanyl, which is a synthetic morphine. It's up to 30 times more potent than regular morphine. And we got to realize that, you know, this can occur, and because it gets in the way of the cell function, especially with diagnostic testing, we need to be able to reverse its effects, and that's why we have Narcan. Now, other types of opiate antagonist medications are out there. We have Dilantin and Cerebix. This does not deal with the same dopaminergic receptors that Narcan affects. These more are talked about with the overall cerebrum and somatic nervous system. That's how it lowers seizure activity. Histamine 2 receptors, now we're moving on to the GI system. Histamine 2 receptor antagonist, when the histamine 2 receptor is stimulated, it causes the production of acid. And the way you want to block that is by giving an antagonist. So we reduce acid, and that will have effects on symptoms of GERD. And with the GI distress that follows it. Zantac, Pepcid, Tagamet are common over-the-counter medications. Antiemetics, and we're talking about things that suppress nausea and vomiting. And you see with compazine is very common that we give now, as well as phenergan. This can be given orally or IV, but realize that it can have some adverse effects. It can have some rebound effects when the patient can overly vomit with it, so you have to be very careful. Reglan will increase GI motility. Patients with bowel obstruction will be on this. And then we have the 5-HT3 receptor antagonist that stop the reactive processes of vomiting, the retching mechanisms. A new type of drug you're going to see, it's a synthetic somatostatin. It's called sandostatin. And the thing with sandostatin is it's very effective in cancer treatment. It lowers the production of growth hormones. Glucagons decreases insulin production. So patients who have overstimulation of certain glands that are usually the precursors to cancer, causes of cancer, this is a good drug that's used to combat it. Acetaminophen, otherwise known as Tylenol, or an acceptable abbreviation is APAP. That's an antipyretic, lowers fever, and there's different preparations for it that you can give, but just realize that it has a very narrow therapeutic threshold, and the index is very narrow. So 15 grams will cause hepatic failure. The liver will fail at 15 grams. It's prepared 500 milligram pills, so you only need 30 pills to go into liver failure. Calcium preparations, well, what we can use it is for an antidote for calcium channel blocker overdoses. Calcium chloride is given in that respect. You can give it cardiac arrest asystole if you suspect a calcium channel blocker overdose. Mag sulfate toxicity, as well as, like I said, asystole it's big, and certain bradycardias. Patients who are hypocalcemic can be given this in small doses. It also helps to prevent hypotension in certain relative hypovolemic states. It's prepared as an IV, either as calcium chloride or calcium gluconate. Calcium gluconate is, you'll hear it's more given for spider bites, black widow spider bite antidotes. You want to avoid subcutaneous or ion administration. It can cause muscular damage and even skeletal bone damage. Dextrose, it's of course given when you have presumed or present hypoglycemia. It's given through large IV catheter. Because it is so thick, it is a hypertonic solution. The hypertonicity of the fluid will actually draw fluid from the interstitium into the intravascular. And you have to be very careful, because if you don't give it through a patent line, it goes into the tissue, it can draw all the fluid from the tissue and cause necrosis. Diphenhydramine, we use it for a vast array of different issues depending on your protocols. It's a histamine 1 receptor antagonist. It blocks the production of further histamine. It does nothing for the histamine that's already there. It blocks further production. Glucagon is naturally occurring. It's created by the alpha cells in the pancreas, and it does the same role as that beta stimulation on the liver. It will tell the liver to convert its glycogen stores into glucose and send it out into the blood. In addition, it has been known to treat severe calcium channel blocker overdoses by affecting mitochondrial processes, and it's given in a systole that you suspect a calcium channel blocker overdose to be administered, to have been the cause of. It also is a smooth muscle relaxer of the esophagus, and when you have a foreign body lodge and it can't be moved, it's actually been known to be effective IV for that. Now, some miscellaneous medications that you have, ketorolac. This is an alternate to an opioid analgesic. It's actually an NSAID, so it's given to patients who are in pain, but they're limited to their medication because of habitual abuse histories. But be careful, because it can cause GI bleeding, so be very cautious when you have a patient who is either active or has a history of GI bleeding. Mag sulfate, it's an electrolyte medication. You can give it in cardiac arrest for VFib, torsade de pointes, and also it can be given for severe asthma attacks, reactive airway diseases that are refractory to your first-line treatments, epinephrine and albuterol. So true status as MAC is it really aids with that. It's a smooth muscle relaxer. Sodium bicarb, alkalizing agent, administered by either a rapid IV push or added to the IV fluids. You give continuous infusion. A lot of times you see this with patients who are suffering from compartment syndrome, crush injuries. Also cardiac arrest with prolonged periods where you're concerned about metabolic acidosis. Thiamine is a vitamin B. It's given by IV route. It can have toxic and adverse effects, but really pre-hospitally we're not going to be that concerned about. They're not going to have an overdose on 100 milligrams of thiamine, but you have to be cautious of that. You might see a patient have a seizure or go into a mentally psychotic state. All right, so let's talk about medications that you're going to find on your ambulance. Specific medications that follow the New York State formulary. You understand with the emergency medication that you're giving, their names, correct names. You may have a trade name drug, you may have a generic name drug. So you got to know the different names. Just remember that with trade name drugs, they have to have the generic name underneath it in parentheses. That is an FDA regulation, so just keep that in mind. Know their effects, when they're indicated, the route, the accepted route for that specific drug, and dosages that are accepted. What their actions, contraindications, any complications, any side effects or interactions that you have. So having that comprehensive understanding of all medications is vital. Okay, we need to be able to make quick decisions, know when to administer medications, but do it after a thorough interview or assessment. Stay up to date on latest pharmacologic information. You might go on vacation, and in the week that you're on vacation, the literature could change on a medication so drastically that it's no longer in your box when you get back. So this is how dynamic our industry is. Now, American Heart Association classifies drugs. Now, this is unlike the antidysrhythmic classification. Don't get the two confused. So this is the general American Heart Association classification, and it talks about the efficacy and the hazards. So a class 1, a treatment should be administered. Class 2 is broken into 2 categories. Class 2A, it's reasonable, and class 2B, think about it, but it could have some problems. Class 3, it's harmful, not helpful. And then class indeterminate, because the American Heart Association makes classifications based on research, there are some drugs that have not had research performed on them for over 25 years, like lidocaine. Okay? Just because you know it works, there's no studies that proves it works, so what the HA is forced to do is label lidocaine a class indeterminate. Pregnancy classifications, once again. Category A. Possibility of fetal harm is remote. It's very safe, the safest of these drugs to use. And then category B, well, we did some studies and we didn't really see it. Category C, give it only if the benefit to mom outweighs the risk to the uterus. Category D, there's definite positive evidence of fetal risk. We see that with benzodiazepines like diazepam. But the benefits that you're giving it to the pregnant patient can have a better overall outcome for the fetus. In other words, mom's seizing, and because she's seizing, she's not breathing, therefore the child is hypoxic. So what are we weighing the options? So we're going to give the Valium to stop the seizure. We're going to risk the Valium being absorbed by the fetus, but the fetus is now getting oxygenated blood again. Then category X, don't do it no matter what. We call it a black box warning. Remember our Controlled Substance Act of 1970? This is where we put them into our different categories based on their abuse and clinical use. When you're talking on the radio, asking for medications, common terminology is key. Okay, remember to use accepted forms of abbreviation. Know your metric conversions. Understand that 1 kilogram is the equivalent of 2.2 pounds. Unfortunately, we don't work in Europe, or if you do, you're at an advantage because everybody knows how much they weigh in kilos. Here in the United States, everybody knows how much they weigh in pounds, so we have to do the conversion in our head. So we're doing the drug dose calculations. It's very important that we understand what is the desired dose. The desired dose is what the drug that you want to give. So if the physician orders you, or a standing order says you give 40 milligrams of Lasix, that's the desired dose, 40 milligrams. The concentration is the amount of medication that's present in the vial or the IV bag in milligrams per ml. Okay, that's the solution concentration. Volume is the amount of fluid that it's dissolved in. And what is the yield? The amount of drug in 1 cc. Understand the names of medications. There are common names, there are generic names, there are trade names. and know the classes of drugs. Understand the mechanism of action of each drug. When is it indicated? When is it contraindicated? What are some adverse or side effects that you want to look out for and be aware of? Like having an EpiPen, when you're going to give the EpiPen, know that one of the adverse reactions is VFib, so have the patient on a monitor. And see how they interact with the drugs. That's when we talk about nitrates with erectile dysfunction medications. When you're restocking your drugs, you're going through your bag, see how the drugs are supplied. They can differ based on the way that the drugs are manufactured and distributed to the marketplace. And you've seen over the past 5 years, almost every year, there's a new drug shortage. And then when you get a new drug, it's in a different form. Or we have to, as administrators, create drugs for you behind the scenes, so it may not be the type of delivery method that you are used to. So you got to be aware of this. Know how the drug works, the duration. When does it when do you first start seeing effect? What's its peak effect? How long is it going to last? When do we look at things like that? Well, how about adenosine? When it's its onset? The onset of adenosine is about 10 seconds. The peak effect is about 20 seconds, and the duration is 30 seconds. So in that 30-second window is the entire process performed. And then look at special considerations. Like adenosine, do I have to give it with a rapid IV flush after it? Look at interactions. So let's look at some of these drugs, just an overview, talk about the mechanism of action. I'm going to speed up. If you need to pause to really read this, that's fine. So we're just going to do kind of an overview. So, activated charcoal, what does it do? It absorbs toxic substances in the GI tract, acts like a sponge for chemicals. Contraindicated for comatose patients. It's not given for every type of poisoning, ingestion, so you need to discuss with medical control. And some vomiting can occur, so you got to be aware of that. Make your ambulance ready, because there's nothing worse than cleaning activated charcoal from inside your cabinets. Adenosine, what's its mechanism? It slows conduction through the AV node. By doing that, it interrupts something known as the reentrant pathways that are very common in supraventricular tachycardias. The great thing about adenosine is that at 6 milligrams, it doesn't work. And what do I mean by that? It works, but it's not long-lasting. And you've seen it when you've given adenosine. The patient will have that quick run of VTAC for four beats, and then go asystolic, will take a collective sigh, and then they suddenly start having a beat. And it could be atrial fib, it could be a flutter with 4-to-1 conduction, it could be sinus, but whatever ends up happening, in about 10 seconds, it goes back into SVT. But what it's done, the ineffective 6 milligram dosage of adenosine, is giving you a 10-second little stop animation to see what the underlying rhythm is. So it's like it paused, and now you saw it slow into atrial fib. Then it sped up again. So now it's no longer SVT, it's now rapid atrial fib. It allows you to make a more definitive interpretation. And your treatment will now change. Now you'll think about a calcium channel blocker instead of 12 milligrams that you would give if the patient went into a slowed sinus rhythm and then sped up again. Now you know it's atrial tach, and at 12 milligrams it usually suppresses. Albuterol, I think we've beaten it to death, right? We understand its actions, its indications, and its side effects. TPA, this is a fibrinolytic. It restores perfusion. Used with caution with patients who have history of bleeding disorders, things like that. It's the rotor-rooter of the liquid plumber of the cardiovascular system. It gets rid of clots. in the coronary arteries, but clots everywhere. So you're at risk for GI bleeding to non-traumatic brain injury. So be very careful, and of course a lot of systems have that TPA checklist. If you're not going to be given it in the field, but when they go to the hospital, you hand them the checklist, it helps speed that door to needle time that a lot of hospitals look for. Amiodarone, remember it's a class 3 antiarrhythmic. Okay, it's going to slow conduction of the calcium channels, potassium channels, and sodium channels. Adverse reactions we have, dizziness, fatigue. It's a pregnancy safety issue, category D. But when are you giving it? During tachydysrhythmias or in cardiac arrest, where treatment from mom is going to be beneficial to the fetus. Amyl nitrate. Now we think about an agent that we give for toxicity of cyanide. It's part of your cyanokits. It converts hemoglobin to methemoglobin, and what that does is it prevents it from being affected by cyanide. Aspirin, chewable aspirin, otherwise known as baby aspirin. It's aspirin that's not enterically coated. And so because it's not enterically coated, it can be dissolved in the oral mucosa as a faster onset than aspirin that has to be digested. It's a category D, but once again, why are we giving it? Mom's having chest pain. She's in cardiovascular distress. That can have a problem delivering oxygen to the fetus, so it's all relative contraindication. And ironically, they call it baby aspirin, but it's not recommended in the pediatric population. Don't ask me why. Okay, atenolol, now we're talking about a beta blocker. So beta blockers, what do? They block sympathetic tone and the beta receptors on the heart, so we're going to have a decreased heart rate. It's good in the MI setting to reduce the workload of the heart, but it's contraindicated in issues like symptomatic bradycardia and heart failure. It's a pregnancy safety category D. You got to give it slowly, and be careful of people who have liver or renal dysfunction as well as COPD, because when you give a beta agonist, it's going to be blocked. Atropine sulfate blocks vagal tone, and by blocking vagal tone, it now allows the release of sympathetic tone. So it's an anticholinergic. Benzocaine spray, otherwise known as Hurricane, its actions are basically to block the receptor sites in the nasal mucosa. So it's something that's given when you're doing nasal procedures, nasal airway insertion, nasal intubation, and any nasogastric tube, something that's going to stay in there for a while, it's going to cause inflammation. Bumex is a type of diuretic that is, instead of being at the loop of Henle, it's at the ascending loop, so it doesn't have as hard an effect on sodium levels in the blood, because the sodium is going to start getting reabsorbed at the descending portion of the loop of Henle. So what it does is it prevents reabsorption of sodium at the ascending, so sodium has already been reabsorbed, so we won't have profound hyponatremic qualities that you would have with Lasix. Calcium chloride is going to increase cardiac contractile state by overwhelming the calcium channels in the SA and AV nodes. Calcium glutamate counteracts toxicity of hyperkalemia. It's also good for spider bite injuries. It's contraindicated in DIG toxicity and VFib. Plavix inhibits platelet aggregation. It's great. It's used post angioplasty to prevent reoccurrence of clotting and allow the coronary arteries to have good perfusion. Be careful with patients with active bleeding issues. Dexamethasone, this will suppress acute and chronic inflammation. It's used in anaphylaxis, asthma, as well as spinal cord injuries. Patients who are hypersensitive, use with caution with sepsis. It's really something that's fallen out of favor in the head injury arena, but is still nationally used. Dextrose has never fallen out of favor. It is one of your staples of medications. Valium is given to raise seizure threshold by introducing chloride, which is a negative ion, which lowers the polarity of your brain cells and makes you sedated. It's a hypnotic, meaning you feel pain but don't remember it. It's a very weird drug. When you ever give it to somebody and you do a painful procedure like cardioversion, they'll yell out in pain but not remember why they yelled out in pain. Digoxin, otherwise known as Lanoxin, it's going to increase myocardial contractile force and yet slow reentry rates. So it's used for rapid atrial fib, but it also increased contractility. Because remember, you want to increase contractility because patients in atrial fibrillation don't have that atrial kick anymore because their atria are fibrillating. So when they have that loss of atrial kick, that's like 20 to 30% of your stroke volume. So what you want to do is have a stronger ventricular contraction, which will increase your overall stroke volume and ejection fraction. Cardizem is going to control rapid ventricular rates. It is a calcium channel blocker, so it slows conduction through the SA node. Benadryl, diphenhydramine, another staple. It's the drug given for allergic reactions. It has an out-of-box use for dystonic reactions, reactions to Haldol, where a patient has not taken a drug called cogentin, which reduces that tetany in the muscles. It's contraindicated for asthma, glaucoma, and it's a category B pregnancy issue, so it's helpful. And once again, when you're giving it, it's more helpful to treat mom for her allergic reaction. Dobutamine hydrochloride, this is something that's indicated for cardiogenic shock, CHF, left ventricular failure. Delastron, Anzamet, is one of the new drugs that we have now that are used to combat nausea and prolonged vomiting. Something brand new. In the last 3 years, we've got this out there now. It's very difficult to actually interview a patient and deal with underlying issues if the patient is continuously vomiting, and it makes for a bad patient experience. So you're able to actually reduce that vomiting. It works out great for the patient overall. Dopamine, going back to dobutamine, this is the more ingenous hormone than dopamine, which is synthetic, used for the same thing. Epinephrine, if you don't know what epinephrine does and how effective it is, then you're not a paramedic. I mean, this is one of our staples outside of dextrose. It is the primary drug given in cardiac arrest. Racemic epinephrine is given actually to reduce nasal swelling. It's also given in some systems to combat croup. Integralin is a drug you're going to see a lot in STEMI centers. It reduces platelet aggregation, and patients with unstable angina and non-STEMI acute coronary syndromes will get this drug. So they're not showing ST elevation where they're going up to the cath lab. These are somebody with profound angina
that has not had a response to nitro, unstable angina. These are patients that get integral. Autonomic, short-acting hypnotic. It's a great precursor for intubation. It sedates a patient for intubation. It's also now given as an alternative to Valium for synchronized cardioversion, but it's given at half dose. Remember, the dose of Autonomic is 0.3 milligrams per kilogram. Now in New York City, there's a cap on Autonomic at 20 milligrams. So if the question is, a 100 kilogram patient requires Autonomic at 0.3 milligrams per kilogram, what's the dose? The actual dose is 30 milligrams, but if you're in New York City, you're capped out at 20. So when you give for synchronized cardioversion, it's 0.15 milligrams per kilogram. And in New York City, it's up to 10 milligrams. And you do that prior to cardioversion. Fentanyl is, once again, we talked about earlier, it is synthetic morphine. It gives that analgesia and euphoria. It's great for pain management. And that's something new in emergency medicine, pre-hospital care, where we are managing pain. Extremity pain, even abdominal pain, we can manage with opioids. Now, because of the imaging technologies that exist in the hospitals, we don't worry about masking symptoms like we did in the past. Flumazenil, if you have an overdose of a benzodiazepine, this is a drug that will act as kind of the Narcan for benzos, but it doesn't work the same way Narcan does, okay? We only really would give it if the benzo has caused respiratory depression. It's a dangerous drug. You don't want to put someone into a benzodiazepine withdrawal. It can cause seizures. There's a lot of problems that can occur. That's why you don't see it pre-hospitally. It's more of a critical care in-hospital form of management. Cerebrix, this is given for status epilepticus and seizure disorder, and you got to watch out for things like a drop in blood pressure, bradycardias, and other bradydysrhythmias that can occur with it. It's a dangerous drug, and it really hasn't come out into the field yet because Valium works so effectively, as does Versed and other types of benzodiazepines to combat seizure disorder. Lasix, of course, another staple of paramedics. It's a loop diuretic. It's used when you have fluid overload that is causing pulmonary edema. Why has it fallen out of favor in treating all forms of pulmonary edema? When it comes to pulmonary edema that's caused by fluid overload, yes, that's where Lasix really comes in handy. But if it's pulmonary edema caused by pump failure, like congestive heart failure, the real issue is you get rid of that excess water, and because you got rid of the sodium, you're going to make this patient hyponatremic, and sodium plays a very important role in the phases of the cardiac cycle. So we can have issues, all right, with morbidity and mortality by overdosing these patients on Lasix. So now for pump failure, we're looking more at positive pressure, where you find with CPAP to force the fluid back into the vasculature. Glucagon, once again, we give it if we can't get an IV for diabetics. A lot of brittle diabetics have poor vasculatures. So this will create glucose or glucogenesis by converting glycogen stores into glucose, blood glucose. It takes a little bit longer than giving the glucose, but it's still effective. We're also talking about chemical restraints in EMS. And being able to chemically restrain somebody and sedate them, transport, can actually save lives. Instead of having to secure them physically, we can actually cause some problems. So chemical restraint calms them down. Haldol is a great chemical restraint tool. It's going to inhibit nervous system catecholamine receptors. So patients in acute psychosis will do very well with just 5 milligram IM of Haldol. It works, the onset's pretty fast. It is contraindicated in Parkinson's disease, okay, and and an altered mental status that's caused by like a drug intoxication. But one good thing about it is it's not a controlled substance. So some systems are starting to have Haldol as standing order. You don't have to call medical control for it. Heparin is, it works with the clotting factors. It prohibits the clotting cascade. Understand one thing, heparin does not lyse clots. So I'll just shoot back real quick. Heparin does not get rid of clots that are already in existence. It prevents further clotting from occurring. That's why it's a second-line drug after drugs like TPA, after aspirin. Hydrocortisone is an anti-inflammatory, and patients who are in shock due to adrenocortical insufficiency or anaphylaxis are given hydrocortisone as a preventive measure, but it's not your first line, it's a second line emergency medication. Now, the other portion of your cyano kit we talked about earlier, hydroxycobalamin. Hydroxycobalamin, if the amyl nitrate will preserve it will change the structure of the hemoglobin so it can actually not be attacked by the cyanide, hydroxycobalamin will actually bind with cyanide and convert it into cyanogen, which is non-toxic. And all hydroxycobalamin is vitamin B. So when you're doing a cyano kit, you've got the amyl nitrate, which preserves the hemoglobin by converting it into a type of hemoglobin that can't be attacked, and the hydroxycobalamin converts the actual toxic cyanide into a non-toxic form. So this is why a lot of protocols you're going to see will say, you should give it through 2 separate IVs because they will interact with each other in the IV line. But if you only get one IV, you need to give the hydrox first. This is why, because it will work to destroy the cyanide, whereas amyl nitrate doesn't do anything to the cyanide. Now, other drugs, Atarax and Visceral, these are other types of analgesics that are out there that actually they control nausea. Now, the thing is, this controls nausea by potentiating drugs that are already on board. So you don't see them as first-line drugs, they're more second-line. Insulin is the hormone that allows glucose to enter into cells. It changes it's an active transporter. It gets it across, it's a mediator, it gets the glucose into the cells. Atrovent, indicated for persistent bronchospasm. You give it with albuterol, and we call that a combivent. And what it does is it blocks parasympathetic tone. And with parasympathetic response, the parasympathetic nervous system creates that salivation, lacrimation, that mucus production, where sympathetic tone, you're dry. Bronchosol or isotherine, this is going to relax the smooth muscle of the bronchioles. So it's a new drug that's out there. You might see it in some systems as an alternative to your albuterol or combivents. Toradol is a very strong analgesic. It can be given by mouth or injected. Labetalol is a beta blocker. It's used to treat primarily hypertension by blocking beta receptors, lowering your heart rate, and therefore lowering your systolic pressure and reducing the pulse pressure, the mean arterial pressure in your vasculature. Levobuterol, another new type of albuterol that's more beta-2 specific, less beta-1 properties, so less cardiac side effects and more profound bronchodilation. Lidocaine, given that class indeterminate by the American Heart Association because there haven't been any studies on it, it's one of the oldest drugs we have in our bag. Right? It's one of those things that If you've been a medic a long time, you just know it works. You don't know why, you just know what it does. It's a class 1 antidysrhythmic, it's a sodium channel blocker. Lorazepam, Ativan, another type of sedative, analgesic that's out there for seizure management, pain management, and it can be used as a chemical restraint. Magnesium sulfate is a smooth muscle relaxer, but that's in the asthma arena, but it's also used for seizures and a type of VFib specifically known as torsade de pointes, which means is French for turning of the points. It's contraindicated in heart blocks. Okay, so that's an important thing to remember about mag sulfate. Contraindicated in heart blocks. Mannitol, used to combat cerebral edema, good in the head trauma arena. But you got to make sure that it's not given for an active bleed head trauma. So it's very weird how it's given. It's more of a cerebral edema that's caused by an electrolyte imbalance. Demerol is another analgesic and sedative, but if you give too much of it, it can cause seizures. So it's kind of not given pre-hospitally that much because it doesn't have the general acceptance that a morphine or other types of analgesics do have. Albupen, now this is a beta non-specific type of medication. All right, it causes smooth muscle relaxation, so it's used for both asthma and COPD. You see metoprolol more in the pediatric asthma world than the adult asthma or COPD world because of its beta-1 qualities and cardiovascular side effects. Salumedrol, this is an anti-inflammatory that is given after a reactive airway attack has subsided with the bronchodilators. That reduces inflammation, mucus production, and we prevent a reoccurrence of the reactive airway disease. Low pressor, it's a beta agonist that is going to, beta antagonist, I'm sorry, that is going to decrease heart rate. It's indicated for atrial flutter or atrial fibrillation. It's one of those drugs out after cardizem. So once again, it's up to your system and medical control whether they want to go with low pressor or cardizem. It's contraindicated in heart failure and blocks. Versed, another sedative, it's indicated for airway management. It's a great sedative to be given early on. You know, we talk about etomidate or ketamine. Versed falls under that too. So it's your first line sedative for rapid sequence intubation. Morphine, another one that relieves pain through CNS depression. So when is it indicated? Well, it's indicated for CHF and pulmonary edema because it has cardiovascular properties. It causes a process known as venous pooling, which reduces venous return to the heart, lowers preload. And this venous pooling also drops your systemic vascular resistance, and that reduces afterload. So it's something in severe congestive heart failure where the CPAP and the Lasix is not working. We just basically want to get a lot of that fluid out of the equation altogether, so we venous pool with our morphine. Patients with chest pain and is not being resolved with reperfusion, they receive a drug like Nubain, which is another opiate agonist, but is contraindicated in issues like hypotension, hypovolemia, head injury. Narcan, hey, we know what it does. We talked about it earlier. It's an opiate antagonist. It knocks out all of the opiates out of the opiate receptors. It puts you into almost immediate withdrawal. The body begins operating again. And we pretty much know the onset of effect. It should take between 30 seconds to 2 minutes, depending on the route of administration. Nifedipine, otherwise known as Procardia or Adalat, is a calcium channel blocker indicated for chronic hypertension or a hypertensive crisis where the blood pressure is above 110 millimeters mercury diastolic. Angina is a great drug to give in angina. It can drop blood pressure, so we got to be very careful with patients who are hypotensive giving it to them. Nitroglycerin, once again, it's a smooth muscle relaxer. Our targeted smooth muscle that we're looking for is the coronary arteries, causing dilation. That will then allow reperfusion to occur. So it's indicated for chest pain, angina, or ischemic. Be aware of issues with hypotension. So when we're talking about inferior wall MI, where we have ST elevation in leads 2, 3, and AVF, well, you know, there's an issue because it reduces preload to the heart through the vasodilation. People with inferior wall issues have preload issues that affect their blood pressure. So while they're saying that nitroglycerin should be used with caution, it's not saying it's a contraindication. Just try not to give 5 or 6 sprays of nitro to somebody with an inferior wall MI. But the first nitro is fine, but be prepared for that precipitous drop in blood pressure. So positioning of your patient, an IV insertion, is definitely something you should consider before this drug. Nitro paste is nitroglycerin, but it's prepared in a dermal form. Now, a really great type of pain management that's non-narcotic is nitrous oxide. It's called Nitronox. It's mixed with oxygen, a 50-50 mixture. Scientifically, we don't know why it works, but if you've ever been to the dentist, you know that it does work. And it's indicated for moderate to severe pain and is good for people who have issues with medication tolerance and substance abuse issues. It's also patient-driven, meaning you fill up the Nitronox into the non-rebreather and you have the patient hold the mask and put it over their mouth when they feel pain. So in order for this to work, you've got to have a patient who is able to assist in their own care. You can't take this Nitronox and put it over and treat the mask like you would a non-rebreather by securing it to their face. They've got to control it. Okay, and so the contraindications, in addition to the head injury, is altered level of consciousness. Levophed, otherwise known as norepinephrine, is a drug you're going to be seeing a lot in not only cardiac arrest management, but primarily in cardiogenic shock patients. So critical care transport, where you're taking somebody who has pump failure to a heart center, they may be on the Levophed drip in order to maintain their blood pressure. But it's not a frontline drug, it is a last ditch. There was an old saying, Levophed means leave them dead. We want to really use caution with Levophed. When it's being administered, you know, you have to watch for signs of hypertension and increased heart rate. Zofran, now in New York City and in the surrounding regions, this is the drug of choice for nausea and vomiting prevention. The only real contraindication is a known allergy to it. Oral glucose is just what it says. This instant glucose is dissolved by the oral mucosa and is a rapid way to get sugar into the bloodstream to combat hypoglycemia for patients who are able to assist in their own care. They're able to swallow. Oxygen, it reduces hypoxemia. And the amount that you give can affect the actual way it diffuses across into the blood. So increasing it simply by nasal cannula from 21% to 44% can have a profound impact on its ability to diffuse. So think about how the patient is presenting. If they are not short of breath, you can give them a nasal cannula, have a really good response. But if they are short of breath, and in New York State, they say if you're breathing at a rate of 24 breaths a minute or more, you give a non-rebreather during your primary assessment. You can always take it off. That's the greatest thing about oxygen. Oxytocin is a postpartum drug. We never give it while the patient is in active labor. It's done to increase uterine contractions that actually will reduce uterine bleeding. But it's got to be done after all parts of birth have been expelled, fetus and placenta. Pancuronium, now we're talking about some neuromuscular blocking agents. What does it do? It blocks acetylcholine receptors, therefore no sodium channels can open, so you have paralysis. This particular non-depolarizing neuromuscular blocking agent is long-lasting. Phenobarbital is prevention of seizure disorders, and they need to have levels, therapeutic levels in the blood at all times, so this is more of a ongoing chronic regimen of medication. And there is a substance, there is a index for abuse. This is a class 5 controlled substance. Dilantin is to treat major grand mal activity, contraindicated in bradycardia. Now I talked about earlier about Mark II kits and what they do. The atropine blocks acetylcholine receptors, flipping you in a sympathetic tone, but prolixamine or 2-PAM will protect acetylcholine esterase from being attacked by nerve agents or organophosphates. Procainamide is, once again, it's a class 2 antiarrhythmic. It suppresses intraventricular conduction. It's indicated for torsade de Pointes, second and third degree heart block. It's contraindicated for those situations. So it's contraindicated for issues like torsade de Pointes, second and third degree heart blocks. Phenergen, this is another antiemetic, and its mechanism is it's an H1 receptor antagonist. If you were following the Michael Jackson trial, and you know that Michael Jackson died of a propofol overdose. This is a drug that can create an almost instantaneous state of general anesthesia. You go out almost immediately. They call it the milk of anesthesia. It's prepared in a very thick substance, thick fluid. The good thing about propofol is that it works really quick. The onset is, and the peak effect is almost instantaneous. And when you shut it off, the patient wakes up. So it's really the anesthetic of choice in most operating rooms. And you might see it on some critical care transports when you're doing rapid sequence intubation. Propranolol, Inderol, it's used for hypertension and angina because it reduces the inotropy and the chronotropy that the heart is responding to with beta-adrenergic stimulation. So it's contraindicated in sinus brady because they're already slowed down. So once again, it's another type of beta blocker. Another long-acting, non-depolarizing, neuromuscular blocking agent is rocuronium. Paralytic that's given after the patient has been sedated and intubated. The one thing to remember about these NMBAs, while they cause paralysis, they don't sedate. So if you don't sedate your patient and you give them this paralytic, they are awake and paralyzed. Try to imagine what type of anxiety you would feel in that situation. So never forget your sedatives before your paralytics. Sodium bicarb, what is it doing? It's combating lactic acidosis by assisting the renal buffer system. Sodium nitrate is used for cyanide poisoning in addition to the amyl nitrate, and it does that same thing as amyl nitrate. It converts hemoglobin into methemoglobin. Sodium thiosulfate is another drug that you find in your cyan kits, and it works like hydroxycobalamin. It converts cyanide into less toxic thiocyanate. When you talk about fibrinolytic therapy, TPA is the big drug of choice, but we have another drug called streptokinase, and this also works just like TPA. Some studies showed in the early 90s that it was more effective with cardiovascular coronary arteries than the other arteries, but it's still, strepto and TPA are the choice of the cardiologist and what they want to use, but it works the same way. Succinylcholine, this is the depolarizing neuromuscular blocking agent. It causes the fasciculations, the muscle tremors. It's short-acting, but short-lasting, so it's your first NMDA of choice once you've sedated your patient, before you intubate. Terbutaline is a profound beta agonist causing relaxation of the bronchial tree. It's profoundly a beta 2. It's a great drug to give. A lot of systems give it as an alternative for epinephrine in status asthmaticus. Thiamine is vitamin B, and while it's really dropped off the map as part of our altered mental status protocol, it still is, a vitamin is actually good. It helps form an enzyme that works towards increasing production of ATP in the cells. Aggrastat is another platelet inhibitor, and it's used for acute coronary syndrome, where we have a patient with unstable angina or an MI. So it's something also that's given post STEMI, angioplasty. Vasopressin, which is stimulated by the pituitary gland, secreted by the pituitary gland in the brain. It stimulates smooth muscle receptors, is a profound vasoconstrictor, vasopressor. It's one of your second-line drugs in cardiac arrest management, only after epinephrine. In AHA, it can be given instead of epinephrine, and it has a longer half-life, lasts longer, about 20 minutes. In New York City, you can give it in conjunction. So you have to follow your regional, local protocols when giving it in the cardiac arrest setting. Another NMDA, vecuronium, Narconon. This is, once again, after you've sedated and paralyzed your patient and intubated them, this is an ongoing, long-acting, non-depolarizing agent. Verapamil is for SVT, atrial flutter, AFib. So here's the thing. This is one of your secondary drugs after you give adenosine. You give adenosine, you slow down the heart rate, you get that 6 to 10 second underlying rhythm, and it's a flutter, then you call medical control, and you could get verapamil. It's contraindicated, however, in WPW, and of symptom known as the Lown-Ganong-Levine syndrome. It has to do with cardiac cell repolarization. Finally, we talk about IV solutions. We have our colloids and crystalloids. So what do colloids do? They expand plasma volume. Crystalloids are electrolytes. So crystalloid solutions, like normal saline and lactated ringers, that's what we use primarily for not only shock arena with plasma increasing, but also a good route for medication. A type of colloid is plasminate. It increases intravascular volume by having these big fat protein molecules that cause the increased tonicity that draws fluid in from the interstitium. Dextran does the same thing. It's a colloid that it contains sugar. It's thick. When we talk about D50 being hypertonic, this is a hypertonic solution that is infused that draws fluid in. So when is a colloid not really required or contraindicated? Burns. You know why? Because we've got a fluid shift issue with burns. Hetastarch, another colloid, does the same thing. Now we go into our crystalloids. Lactated ringers is the crystalloid of choice in trauma resuscitation because it best mimics your blood plasma concentration of electrolytes. So it's really well indicated for both relative and absolute hypovolemia. Both the anaphylaxis, sepsis, as well as hemorrhagic. Just be careful with patients who have renal insufficiency or CHF getting this drug, getting this fluid. D5W really is the primary and fluid of choice for drug administration. It creates an arena for drugs where they won't, it increases the ability for highest level of biotransformation, 10%, 100% biotransformation. 10%, now we're talking about neonatal resuscitation. And 0.9% sodium chloride, it can replace water and electrolytes. It doesn't have the same electrolytic qualities as plasma mimicking qualities as lactated ringers. It's like the last ditch type of fluid that we have. And of course, ironically, it seems to be the #1 fluid of choice in EMS. You may see changes down the road where we'll go back to the old days of lactated ringers and D5W because that seemed to work a lot better, even though this is more economically viable. Half normal saline is given for patients with renal dysfunction, where you don't want the you don't want the rapid rehydration. So they have renal issues. They're on dialysis. You don't want to involve the kidneys by overstimulating salt. So it's half normal saline. Much slower rehydration as a result. Patients who suffer from heat exhaustion or diabetic issues get the 5% dextrose and half normal saline. It's D5 half normal saline. You find this in the hospitals a lot. And so if you go to a hospital, to the ER, and you're replenishing your fluids, you got to know which fluids to take. You know, you're going for the 0.9 normal saline, not the 5% dextrose and 0.5. It's not a drug. It's not a fluid of choice for rapid fluid resuscitation you find in trauma and anaphylaxis, sepsis. Another type of solution that, once again, is given for heat-related disorders. You're hypothermic, it helps you cool down. It's good for freshwater drowning. This is a good drug for hypovolemic and hemorrhagic shock, the 5% dextrose and lactated ringers, because it's going to deliver oxygen and sugar. So having an understanding of this whole thing, it's a dynamic field, pharmacology. It's changing with science. It's changing as quickly as it takes you to go on vacation. So being up on your pharmacology is key to being an excellent medic, giving optimal patient care. Thank you.